Good afternoon, everyone. Thank you for being here, and thanks everyone who is joining in this virtual meeting. May I introduce Dr. Antoni Trilla, who on behalf of the director of the hospital clinic will present this act and this meet.
Welcome all, and welcome to the University of Barcelona Hospital Clinic. On behalf of the General Director of the hospital, Dr. Capistol, on behalf of myself, I'm the Dean of the School of Medicine, you are very welcome to this World Pneumonia Day. Just a few words for stating that pneumonia, as you all know, is a very severe disease that more than 2.5 million people die every year, from pneumonia, and including more than 700,000 children all over the world. And we have good treatments. We always need better treatments, and we have good vaccines. We always need better vaccines, but we can prevent pneumonia. I'm absolutely confident that you will learn a lot today about the importance of pneumonia, diagnosis, prevention, and treatment. Welcome.
Thank you so much, Dr. Trilla. We are now presenting.
And normally caused by microorganisms, such as bacteria, viruses, and fungi. Pneumonia can be
There may be some problem with the sound. I don't think we can hear.
Thank you so much to Mr. Sergio Rodriguez, which is actually the General Director of Pfizer in Spain. And now the next speaker that will help us in the opening is the Catalan Councillor of Health, is the Dr. Alba Vergés. Buenas tardes, consellera.
Okay, I cannot switch on the video because okay, that's right. It's okay. Can you see me? No? But can you hear me?
Yes.
Yes, okay. Okay, start my video. Now it's okay. Okay, so now you can hear me and you can see me. I cannot see you, but I know you are there. Good afternoon to everyone. I first wish to thank you for inviting me to be with you here today at the Global Conference for World Pneumonia Day. Pneumonia is a common disease with a mortality rate of 10% in hospitalized patients and 30% in those requiring intensive care. However, 8 months ago, many people had not heard of pneumonia outside healthcare environments or only when they were closely hit by pneumonia. COVID-19, among many other things, has made us aware about what pneumonia is and how it affects people, as it is one of the main symptoms or hallmarks of this disease. We know that in Catalonia almost 60,000 people were admitted in hospital due to COVID-19. Only from March to April, cases of COVID-19 pneumonia doubled compared to those in a year. In general, it has affected younger, healthier people. However, mortality rate and the needs for mechanical ventilation of hospitalized patients with COVID-19 are higher than patients with community-acquired pneumonia. This has made pneumonia to be very present in recent times. Yet lately, with SARS-CoV-2 virus as a unique main character, and we are very aware that pneumonia can be caused by other causes. And we must bear in mind these other causes to be able to prevent them. And that is why it is at most importance to make this disease visible. Because if we have pneumonia in mind, we can prevent it and therefore prevent many deaths. A lesson learned here in Catalonia and in the world in this pandemic. Something we already knew and that now has emphasized its value is prevention. This prevention is highly important for pneumonia and therefore in our vaccination schedule, pneumococcal vaccine in children and adults elder than 65 years is included. Because we have always taken care, and even more now, of the most vulnerable people's health. And I say in Catalonia, pneumococcal vaccine is included in its vaccination schedule, being very aware that very different realities are represented here today. Therefore, it is of great value that more than 21 speakers from different organizations committed to combat pneumonia are gathered here today. World Health Organization, Save the Children, UNICEF, Gavi, Every Breath Count Coalition, and the presidents of scientific respiratory societies from all over the world. I would like to congratulate you and your initiative, Pneumolight, Light for the Education and Prevention of Pneumonia. It's of major importance to shed light on all these diseases and make them visible. I think it's more than 200 monuments of 47 different countries, people told me. So this is a big initiative, because they sometimes go unnoticed, these diseases that we have to make visible. They sometimes go unnoticed, but have a great impact on people's health. Let me now close by wishing you a stimulating day and highlighting that the Catalan Ministry of Health commitment on this goal of giving a greater global visibility of pneumonia. Thank you very much. Thank you.
Thank you very much. Gracias, consellera. May I introduce our next speakers, which we introduce our whole seminar. There are two great figures in medicine. One of them is Dr. Antoni Trilla, which is the Dean of the School of Medicine of the University of Barcelona. And the other is Dr. Antoni Torres, which is a full professor of medicine and pulmonology at the University of Barcelona. He's the chair of the research group of applied research in respiratory diseases in the DBAPS, and also the coordinator of the severe group of respiratory diseases. Among all of these charges that Dr. Torres has, he's also my friend and my mentor, and he has prepared a lot of generations of solid investigators who are committed to investigate in pneumonia, in COPD, in ventilator-associated pneumonia, and it's a great pleasure to have you here.
Thank you very much, Dr. Huerta. It is my pleasure to be here as well, and it's an opportunity as well. Now, pneumonia is very popular because COVID, and it has been a disaster, of course. But pneumonia has been here for many, many years. It is the first cause of death from infectious diseases, both in community-acquired pneumonia and in hospital-acquired pneumonia. So it's a terrible disease. Be aware that the World Health Organization called pneumonia in children the forgotten killer. So I think that countries, institutions, organizations have to invest much more in the research of pneumonia, because it's a very common disease that kills a lot of people every year. And not only that, the consequence of short-term and long-term pneumonia are tremendous. Up to 30% of patients with community-acquired pneumonia at certain age may or might die after the follow-up of 1 year. So it's much more important now that other diseases, and I think we have an opportunity to work on that. And thanks to the COVID is bad, but thanks to that, pneumonia, we will have much more awareness of what is pneumonia, because COVID is a pneumonia as well. Thank you very much, and I want to congratulate finally Katia Zillonis for this initiative. This important, she has done a tremendous work with us in our group, and for the organization of this symposium today in the Pneumonia Day. Thank you, Katia.
After Dr. Torres has a speak about pneumonia, the best thing that I can do is to remain silent, just to thank again Dr. Zillonis, Katia, and all the members of the team that has prepared this pneumonia. Thank you very much, and welcome again to this World Pneumonia Day.
Thank you so much. We will start our symposium for the first time with our first speaker, which is also the organizer of the symposium, which is Katia Zillonis. She's a researcher in pneumonia, and he's a fellow of the European Respiratory Society. But she's also a coordinator of the Worldwide Pneumonia Awareness Campaign. Katia, thank you so much for being here, and thank you so much for being stretched to your time. You have 10 minutes.
Thank you, Dr. Huerta, for the introduction. So, good afternoon, everyone. According to the Global Burden of Disease study, in 2019, 2.5 million of people die of pneumonia. This means that pneumonia kills more people than any other infection diseases in the world. This mortality is more than HIV and malaria combined. The most vulnerable population are children under 5 years old and adults over 70 years old. In 2019, pneumonia kills more than 1 million of adults over 70 years old and more than 600,000 children under 5 years old. According to the report, The Missing Piece Pneumonia, based on the data of the Global Burden of Disease 2017, Sub-Saharan Africa and South Asia are the region more affected for pneumonia. Pneumonia is a treatable and preventable disease. So, why pneumonia has such impact in the world? Let me show some facts. There is a lack of awareness about severity of pneumonia and its consequences. Some data here. 1 in 5 patients who are hospitalized with pneumonia requires intensive care. 30% of hospitalized patients with pneumonia presented with sepsis, that is a severe condition. Between 10 to 15 of hospitalized patients with pneumonia presented with cardiac event, especially in the case of pneumococcal pneumonia. Pneumonia not only affects the lungs, but also other organs, causing severe complications. For this reason, we need to improve pneumonia diagnosis and accelerate breakthrough innovations. The early identification and treatment of severe cases of pneumonia are key to prevent deaths. However, the etiological diagnosis of pneumonia is very difficult, especially in children. Pulse oximetry for detecting hypoxemia is an effective and essential tool for identifying severe cases of pneumonia. However, in countries with lower resources, it's difficult to implement this technology and they don't have access to this tool. We also have lung ultrasound. That is another important tool for diagnosis of pneumonia. We should implement this technique in countries more affected for pneumonia. We also should reduce risk factors and prioritize vulnerable populations. National strategies that improve child nutrition and reduce smoking and exposure to air pollution should be implemented to reduce the risks of pneumonia, especially in vulnerable populations. We should provide more access to vaccines. This is the map that shows the countries where pneumococcal conjugate vaccine were included in the National Immunization Program. In 2019, pneumococcal vaccine was implemented in 149 countries. However, in this year, pneumococcal vaccine only covered 48% of the children globally. This means that not every child who should be vaccinated is vaccinated, despite the fact that we know that vaccines save lives. This World Pneumonia Day is in the middle of a global pandemic, a pandemic that infected more than 51 million of people in the world, including more than 1 million of deaths. This pandemic also shows us the weakness in health system in many countries with serious consequences. According to the inform of Amnesty International, more than 7,000 of healthcare workers have died from COVID-19. One factor that contributed this was the lack of protection. We also observed how many countries the hospitalized were complete and full and collapsed, and there was a lack of oxygen for therapy. However, there is a positive side in this pandemic. Let me show 3 points. All authorities understand now the importance of invest and improve health system. All the countries have plans for control this pandemic, so we must maintain these strategies to prevent, diagnose, and treat pneumonia. We also observe the power of the social networks for information and education in this pandemic, so we must continue to use social networks to reach more people and raise awareness about pneumonia. No more words are necessary to understand the necessity of pneumonia awareness campaign. So the worldwide pneumonia awareness campaign that we call Pneumolive, Live for Education and Prevention of Pneumonia, was launched in January 2020 for the Association of Patients with Pneumonia, Pneumolive. Pneumolive is a 5-year non-profit and collaborative project with the main objective to increase visibility and raise awareness about pneumonia. Pneumolive is member of the Every Breath Coalition and has the support of 25 organizations and scientific societies globally. These are the organizations that support Pneumolive. In this World Pneumonia Day 2020, the objective of Pneumolive was increase visibility to pneumonia. For that reason, we decided to illuminate iconic landmarks in color blue around the world. So, tonight, in the World Pneumonia Day 2020, 253 iconic landmarks in 167 cities across 51 countries will layer blue for pneumonia awareness. This was possible thanks to all the support of many people, and especially to the solidarity and support of all the authorities around the world that understand the importance of this global campaign. Associated to this campaign, we organized the Global Conference for World Pneumonia Day. The objective of this conference is to understand the problem of pneumonia from the point of view of the main organizations that fight against pneumonia around the world. We will discuss 7 main topics in this conference. We believe that this will help us to understand why pneumonia is a neglected disease and how we can change this. Finally, I want to thank to all the speakers for support us and for sharing with us their experience. And also, I want to thank to Lee Greensline for her support and guidance in this project. Thank you.
Thank you so much, Katia, for your speech. And we'll start our symposium this afternoon by dividing this symposium in 2 or 3 blocks. We will start doing the what is the situation of pneumonia in the world, and we will speak carefully about what is happening, what is the global situation of the childhood pneumonia. For that, we have the presence of Lee Greenslade. Lee Greenslade is the coordinator of the Every Breath Counts, which is basically a coalition of 40 organizations around the world. And they have joined forces to support governments to tackle and leading all these infectious diseases in children pneumonia. So we will hear what she has to say, and thank you so much for being here, Lee.
Terrific, thank you. Hospital Clinic Barcelona and University of Barcelona for hosting us on World Pneumonia Day. And especially thank you to Dr. Katia Sionis for her vision and leadership in bringing us together today. A few weeks ago, the Global Burden of Disease released its 2019 estimates. What do they say about pneumonia? Let's take a look. So pneumonia kills more people than any other infectious disease. 2.5 million deaths in 2019, as Dr. Sionis mentioned. No other infectious disease comes close. 5 million deaths. Unlike most infectious diseases, pneumonia deaths are very young, 75% among children under 5, adults over 70. This is the U-shaped curve that pneumonia takes across life, tuberculosis and HIV/AIDS, which have an N shape, peaking in the adults of workforce age, and malaria, which has an L shape, peaking among children, something that makes pneumonia.
Okay, we have Lit. I think we missed you. We're trying to reconnect with you. We have had some connection problems. Do you hear us, Lit? I'm not sure if she's hearing us. Lit? I think we will move to our next speaker and see later if we can have Lit back. So we will now, our next speaker is Dr. Quique Bassat, which is an ICREA research professor, and he's the head of the malaria program. And he will give us his personal vision on how is the situation about pneumonia in children.
Thank you very much. I hope Liz can join and follow me after this, if she can reconnect. Allow me to share my screen, and I hope you can see my slides. Can you hear me and see me well?
Yes, we do.
Thank you very much. So I think rather than trying to follow what Liz has to say, it's always very difficult to talk after Liz because she's so articulate. I wanted to discuss a little bit today in a nutshell, what are the research and innovation novelties in recent times in relation to decreasing pneumonia deaths, particularly in low and middle income countries. So why innovation and why research? Research is obviously fundamental for a better understanding of the pneumonia burden, the trends, the risk factors for mortality, and obviously for the design and evaluation of the new tools that we come across with for prevention, diagnostics, and treatment. However, we do have a big disbalance between the burden of disease that pneumonia causes, causing more than 25% of all the infectious deaths, and the international funds that are allocated for pneumonia research. And among all infectious disease research funding, only 3% is actually spent at an international level on pneumonia. Most pneumonia deaths are preventable through innovations in prevention, diagnostics, and treatment. So let me try to divide in three sections. First is trying to innovate in the epidemiological knowledge. And of course, we have the landmark study of PERCH that provided the best possible picture of what is causing pneumonia today and what is all the associated risk factors and mortality caused by different pathogens related to pneumonia. And in the figure, you can see among the 7 sites participating in the PERCH study, what were the ranking of pathogens most frequently detected causing pneumonia. However, even though this was a case control study, and therefore we should have been able to understand adequately what pathogens were more associated to causing pneumonia, and to the surprise of many, detection rates in the nasopharynx among cases and healthy controls was in many cases similar. And therefore it made it rather difficult, and that could explain why it took so long to come up with the results, to actually attribute causality. There were additional problems with the finding of the pathogens because the attribution of causality was in many cases done according to the nasopharyngeal samples, the results in the nasopharyngeal sampling. And one could question whether the nasopharynx is a good proxy for what is really happening at the lung level. Further question is, what is the role of mixed infections, and overall, what is the real contribution of pneumonia to overall mortality? And in order to try and solve some of these problems, there's been big progress in providing better methodologies to actually investigate the cause of death for any case. And you may very well have heard of the CHAMPS network, which is a network of 7 sites designed to continue for many years to go to conduct comprehensive mortality surveillance of all deaths in children under 5, including stillbirths. In the map, you can see the sites where this network is actually having activities. And one of the novelties of this mortality surveillance program is the utilization of postmortem non-invasive or minimally invasive methodologies, like the one pictured in the figure. And through the use of this minimally invasive tissue sampling or minimally invasive autopsy technique, you can obtain tissue samples from the key organs and bodily fluids that allow you for a much more detailed and thorough assessment of the underlying etiology. And I've chosen a couple of pictures in which you can actually see the consequences of the infection at the lung level, but also you can locate the pathogens specifically in those places where you identify the lesions. What have we learned through this program that is ongoing in terms of the contribution of pneumonia to infant or child mortality? Well, if we focus on the infant group as an example, among the cases excluding the first 7 days of life, which of course you all know behave in a different manner, we can see that as the underlying cause, pneumonia is present in 11% of the respiratory infections. That could be misleading because if you actually look at the entire chain of events, and through CHAMPS we can actually build the full story of what happens from the moment you become ill to the moment you die, pneumonia then can be found in the causal chain in more than half of the cases. And if we look at the pathogens that we are able to detect and attribute causality in terms of causing lung problems, you would notice that the first 2 pathogens detected are not necessarily in the list that the PERCH study picture as the most frequent pathogens. There may be many explanations why Klebsiella or Acinetobacter are more frequent in those fatal cases, but I just wanted to point out that through a program like this, we will be able to understand much better what is killing children and what is the exact role of pneumonia in terms of causing mortality in children. I also wanted to picture a few examples of innovation in triaging, risk stratification, and diagnostics. And I've just chosen a few examples of new innovations that are available at the moment, starting from respiratory rate monitors, which are automated, and breath counters, a big innovation that has occurred through the Arida La Caixa program with UNICEF in the last 5 years. Going to pulse oximeters that now can do many more things than only looking at saturation of oxygen, including checking at the same time hemoglobin or checking at the same time the respiratory rate. Automated auscultation devices, lung ultrasound, mHealth tools, biomarkers, diagnostic and prognostics, and in the following slide I will explain a little bit more. Risk stratification scores and novel diagnostics. These are just a few examples of what is actually happening at the moment. But in terms of the idea of the use of biomarkers that can actually be detected in blood or in plasma, we've often been using these kind of biomarkers to try to ascertain the underlying etiology. So if a certain biomarker was raised, we could attribute the pneumonia episode to a bacterial cause or to a viral cause, which of course is very useful to guide management. But more useful perhaps than a biomarker that tells you what treatment you need to do is a biomarker that could actually tell you how likely is this patient to die. And there's been enough innovation in the last years to be able to say that biomarkers of endothelial and immune activation that are common to different pathways of severe disease in many different underlying etiologies like sepsis, malaria, dengue, COVID-19 even. Biomarkers like angiopoietin-2, STREM1 could actually help the risk stratification of patients at first encounter and guide on the management. And if you were to use a traffic light looking system of stratification, you could say that depending on the results of those markers, you can actually allocate the scarce resources that are available in some of the low-income settings. So this is just another innovation that is present that of course needs to be validated and compared against the standard of triaging practices in low-income settings, but that can offer an objective way of measuring the risk. Ultrasound, I've mentioned this before. Of course, the utility of ultrasound is that it's point of care. It can reach those most difficult to reach, doesn't irradiate, and it's easy to operate even by non-clinicians. We've shown this in a rural setting like Manisa in Mozambique, where nurses were trained to operate these kind of devices. It provides a real-time diagnosis, or can capture the images and be sent by email or by WhatsApp, so that you can provide also a telemedicine diagnosis. And of course, it's not only useful for pneumonia, it can be useful for many other purposes. So lots of potential for this diagnostic technique that in the next years is called to play a major role in the diagnosis of pneumonia. And finally, let me tell you a couple of words about innovation in management. And of course, there are many avenues in which you can innovate in terms of management. We need better child-friendly antibiotic formulations. We need different schemes of duration of the treatment. We need to bring the treatments to where they are most needed, particularly in those settings where access to health is difficult. So community-based approaches for the delivery of treatments are also necessary, and this is also part of the innovation. But most importantly, and I think today, in a day like today, we need to talk about oxygen. Oxygen is the major area in which we can have big improvements at the moment. And I've just chosen a few images that summarize the ways we can try to provide oxygen, store oxygen, deliver oxygen to those that most need it. And there are foundations specifically dealing with this, like the Free-O2 Foundation. But the most important thing is that in those settings where the pneumonia burden is the highest is where most of the action is actually taking place. Like, for example, the image in the bottom left, where a full oxygen producing unit has been built in a Malawian hospital. Bubble CPAP also offers lots of possibilities. And of course, in most of the low-income settings, we don't have access to ventilation. So having something that can increase the effect of oxygen delivery on its own is always welcome. But we need to look at the opportunities that the COVID crisis has brought. And I've also chosen a few pictures by which we can demonstrate that the world has come together because of COVID to actually produce innovation in terms of devices that can help us ventilate those patients that need ventilation. And these are only a few pictures of devices produced by many different people. I just wanted to mention specifically the SEAT company, a car company that is here based in Barcelona, that was actually able to produce ventilators using windshield pieces from the car industry, in the same way that these Afghan girls have come across a device which has similar potential. So lots of opportunities that COVID is giving. Of course, COVID is a true drama for the world at the moment, but us from the pneumonia world, we need to take the opportunity, we need to seize the opportunity and catalyze all the efforts that are being made for COVID and try and expand them for pneumonia in general. Let me finish by a memory. A few months ago, at the end of January, we were meeting all here together in Barcelona, and it's great to see many of you that were in that meeting today in this meeting. And we had the Global Forum of Childhood Pneumonia, in which we were trying to highlight all the needs that this very much neglected disease has. The world has changed a lot in the last months, but the problem of pneumonia remains as big or even worse than it was. So I'm hoping that through activities like today, and I want to thank Katia Ziloniz for all her push in terms of the organization of this event, we can bring back the field of pneumonia to the general wider community. Thank you very much.
Thank you so much, Kike, for your excellent talk. Before going further with the next speaker, we will go back to Leith Greenslade, which we lost because of the bad connection problem, which is a normal problem when we're live. Can you hear us again, Leith?
I can hear you. Can you hear me?
Okay. We can hear you.
Great. Let's try again. So we were up to this slide, just showing how pneumonia deaths are concentrated in a very small number of countries. So although we have a large number of deaths, we have a very small number of countries that are actually responsible. And you can see there the 10 countries that are responsible for 70% of all child deaths. Let's just make sure we're at the right, okay. Yeah, first of all, that's where I want to be, great. 10 countries account for 50% of all deaths of all ages. And you can see on this list, there's a mix of countries across low, middle and high. Only in the very high income countries like Japan and the US are pneumonia deaths concentrated amongst the elderly. In most other countries, there's a mix, what we call the double burden of child pneumonia deaths and older adult pneumonia deaths. And now let's talk about children. We've heard many times pneumonia, it kills more children than any other single cause. It's very close to preterm birth, but it is still ahead according to the Global Burden of Disease 2019. Now for children, it's even more concentrated, the deaths. 10 countries account for 70% of all child pneumonia deaths. And for the first time this year, Nigeria pulls ahead of India for the country having the most child pneumonia deaths. You'll notice most of those countries are in sub-Saharan Africa, although India, Pakistan and China still make the list. The risk factors, really important for childhood pneumonia: wasting, air pollution, mainly indoor, and low birth weight are now the 3 leading risk factors for child death from pneumonia. This means we must engage the nutrition community, the air pollution community, and the newborn community. They all have a major role to play in reducing the deaths from childhood pneumonia. Once again, we have to talk about the pneumococcal conjugate vaccine, one of our most powerful tools to prevent a leading cause of bacterial pneumonia. 52% of the world's children still do not get this vaccine. Gavi is making great strides to try and close that gap. We have a new vaccine from the Serum Institute of India, which is now more affordable, but we have many non-Gavi eligible countries with very low coverage of this vaccine. We need a big push to get these countries, Gavi and non-Gavi, to fully protect their children with this very powerful vaccine. This may be the most important slide I present to you today. We can't say much about the proportion of children who receive a correct diagnosis and treatment for pneumonia. That's a shocking statement for the leading killer of children, because we simply don't measure. Countries and global health agencies do not measure correct diagnosis or treatment with pulse oximetry, with oxygen, or the recommended antibiotic. We have to change this, and it's one of the major goals of the Every Breath Counts Coalition to work on this area moving forward. Now we want to talk about the interplay briefly between COVID-19 and pneumonia, because they're two sides of the same coin, something I think the world hasn't quite woken up to yet. This group of low middle income countries has very high numbers of child pneumonia deaths and very high numbers of confirmed COVID-19 cases. This means their health systems are struggling with 2 populations needing respiratory care and where infection control can benefit them. Our argument to the governments and global health community is, if you approach this problem in the correct way, you can solve 2 problems with 1 set of solutions. Investing in COVID-19 control is also going to help you achieve your long-term goal to reduce pneumonia deaths, especially among children. If we don't do this in this way, if we don't take this moment, this pandemic, to try and address the underlying needs in respiratory infection control and care, the stakes are very high. We know that COVID will cause a lot more deaths, including from pneumonia, mainly among adults. But we also know that disruptions to services like vaccination, reduced care seeking, and tragically increases in child malnutrition from poverty, increases in poverty as a side effect of the pandemic, could also increase non-COVID-19 pneumonia deaths among children. So I want to leave you with this thought. What could happen in 2020 is the world could endure 1.9 million COVID-19 deaths. That's what the IHME predicts will happen, 1.9 million by the end of this year. Now, we already have 2.5 million pneumonia deaths from non-COVID causes. That number could actually go up in 2020. And we put this massive burden of death together, we could be looking at 4.4 or 4.5 million deaths from pneumonia and COVID-19 in 2020. This will be the largest burden of death by a long way that the world has ever dealt with. And it argues the major lesson for me is that COVID-19 has taught us that respiratory infection control and care must be a top priority for every country, low, middle, and high income, and a top priority on the global health agenda. I'm looking forward to the conversation today. We have a terrific group of actors speaking, and also on YouTube, our audience on YouTube listening. And now is the moment when we need to make great strides forward in pneumonia control to benefit children. And of course, we must never forget older adults. Pneumonia is a major killer across the life course. Thank you so much.
Thank you so much, Leith, again, for your brilliant talk. There is a lot of awareness now about what is happening in children all around the world. There are different ways that every country is tackling the impact of COVID-19. In every country has its own strategy. We have now our next speaker is Dr. Chisova Wonodi, which is actually the doctor who founded the Women Advocates for Vaccine Access. This organization is a coalition of the civil organizations of several organizations in Nigeria. And what they do is they advocate to increase the uptake of vaccines around Nigeria and do a sustainable financing of this access of all the population to this program. So thank you, Dr. Chisova Wonodi, to be with us this afternoon.
Thank you very much, Dr. Katia and the organizers for inviting me. I'm pleased to be here this morning, my time. I'm speaking from Baltimore. So I'd like to share my screen, if that's possible. Okay, I think, can you see my screen?
Yes, you can use it.
Can you see my screen though?
We see you now.
Okay, great. So I'm going to talk about pneumonia in Nigeria, the way forward. And this talk is really based on a commentary that myself and a couple of other colleagues made in pneumonia supplement that was coordinated by the Every Breath Counts coalition. So really to thank the Every Breath coalition for great work that they're doing in really advancing the advocacy and visibility of pneumonia issue in Nigeria. So I'll talk briefly about the burden in Nigeria and why the trends in pneumonia deaths and cases are the way they are. And then I will now touch a little bit about sort of the big picture health systems challenges that have led to the current situation of pneumonia in Nigeria, and then highlight some positive changes that are beginning to emerge in the country. So as we know, pneumonia is the leading killer of children in the world, and I will not rehash what Leith has so eloquently laid out. Just to note that for Nigeria, being now, I can hear now overtaking India as a country with the largest number of kids with pneumonia is, that's quite challenging. And we know that COVID-19 is also going to make the issue a problem for many low and middle income countries, including Nigeria. So this slide kind of tells you, even though Nigeria is, has one of the highest cases of pneumonia in the country, childhood pneumonia in the world, there are some positive things. We can see here that overall there's been a reduction in mortality caused by pneumonia over time. Globally, I think it's about half the mortality. The mortality has been halved in the last 15 years or so. In Nigeria, mortality has also declined. only about 8% that mortality has declined. And if you look at other countries here, you would find that similar thing is happening in India, Pakistan, Ethiopia, Democratic Republic of Nigeria, but we still have a long way to go in terms of reducing both the number of cases and the mortality from pneumonia. So there is a clear-cut action plan for how pneumonia can be prevented and controlled. This is illustrated very clearly by the UNICEF and WHO GAP-D that talks about three major approaches, three major strategies to protect, prevent, and treat. So I'm going to use as a framework for discussing what the pneumonia picture is in Nigeria. So how are we doing? We've seen that there has been a reduction in deaths of pneumonia, but that reduction is slower than globally. So how are we doing in terms of the underlying strategies that will get us where we want to go in terms of pneumonia? So under prevent, so we have protect, and under protect you have things like exclusive breastfeeding, adequate complementary feeding, vitamin A supplementation. To prevent pneumonia, primarily you have vaccines, hand washing, reduction of air pollution, HIV prevention, and treatment, prophylactic treatment for kids that are HIV infected. And then for treatment, we have to ensure that there's improved care seeking, good referral, strong case management, availability of the supplies, and then breastfeeding. So how are we doing on protect? So protection, really focusing on exclusive breastfeeding for the first 6 months, which has been shown to be quite powerful, as in kids who are exclusively breastfed are 15 times, who are not exclusively breastfed are 15 times, have the higher risk of pneumonia mortality. So you see here that in Nigeria, exclusive breastfeeding is actually quite low compared to other countries. The highest we've achieved is around 30% in the current DHS. And over time, it's improved, but we still have much more to do. I know that earlier, maybe in the last decade or so, there was a lot of focus on exclusive breastfeeding with baby-friendly hospitals and initiatives, but unfortunately, that has actually regressed, and they probably need to revive that as well. In terms of prevent, I want to focus on some key vaccines. So vaccination against Hib, pneumococcus, and measles. These are the major vaccines that support prevention of pneumonia. Nigeria introduced the Hib vaccine in around 2014 and 2013, I believe, and then the pneumococcal vaccine around 2014. So here we see that following the introduction of the pneumococcal vaccine, coverage has risen, but it's still much lower than expected targets. So right now it's around 58% of children 1 year of age have received their third dose of PCV. So in terms of vaccination, there is vaccination, there's the appropriate vaccination program in the country, but we still need to ramp up coverage of vaccination among children in order to achieve the objectives that we desire to see. In terms of treatment, how are we doing on treatment? We know that improved care seeking, proper case management, and the availability of low osmolarity ORS, zinc, antibiotics, oxygens are critical, they are fundamental to reduce mortality among cases. So generally speaking, care seeking is poor. If you look at the graph on the right-hand side, it's looking at the proportion of children who, with symptoms of pneumonia, who were taken to a health provider over time. And you can see that over time, not more than 50% of children who have these symptoms were taken to a health provider. And the trends are even declining in the last, would I say, in the last 10 years. So why is this picture this way? First of all, you need to think about the fact that healthcare in Nigeria is is really driven in the healthcare financing is driven by private financing. 70% of treatment cost and healthcare cost is paid out of pocket. So that really puts a burden on families. And then besides care seeking, what about case management? You know, Nigeria is a country with malaria endemicity. And so there's usually this confusion about diagnosis, especially now that a lot with the use of RDTs, a lot of cases that may have overlapping symptoms with pneumonia could be diagnosed as malaria, given that parasitemia is actually quite common even in healthy children. So a very good paper by Graham here talked about that there is quite a bit of diagnosis, misdiagnosis when you use the WHO classification of severe pneumonia, and this may result in delayed administration of antibiotics and proper treatment. Another key challenge is the availability of oxygen and the availability of antibiotics. I know there are current efforts now to ramp up presence of oxygen in hospitals, but there's still quite a lot of ways to go. And then even the simple oximetry, previously there was quite a scarcity of it in hospitals, but now efforts are on the foot to make sure that those are available. So why has progress in pneumonia been slow in Nigeria? So going big picture now and looking policy-wise, I would say that there are three major issues that has compounded the chronic weak healthcare system that we have. So there's a funding gap, there's a coordination gap, and there's an accountability gap, and that has to do with availability of data. So looking at the healthcare system as a whole, this is a complete different talk on its own, but just to highlight that over time, the healthcare system has really grown under poor funding, inadequate human resource, crumbling health infrastructure, high cost of care, coupled with the high cost of out-of-pocket expenditure for parents, and then the unavailability of essential medicines. I mentioned oximetry, antibiotics, oxygen, and co, and then poor healthcare workers. And then on the demand side, particularly among parents with low education, there is poor awareness of symptoms and late care seeking. And then also the fact that the out of stock syndrome, like when you go to a clinic or a public clinic and there are no drugs, the drugs are out of stock, parents begin to distrust the availability of services and they may not even go to health facilities first. And then finally, there are financial and geographic barriers that parents face in seeking early care for their children who are sick. So for pneumonia, we know that pneumonia is a multi-sectorial or has to have a multi-sectorial approach. When you think about air pollution, it's not the health sector that's going to address air pollution issues. When you think about nutrition, it's not just the health sector that will address nutrition. So you need to bring in both the agricultural sector as well. So what we found is that there is a gap in funding for all the range of interventions that are required. And somebody had mentioned this earlier, that when you think about the funding for pneumonia, that only 4% at the global level, only 4% goes to diagnosis and treatment in terms of the research. But what Nigeria did in the last 10 years is really to establish the Saving 1 Million Life initiative that provided funding and coordination to boost maternal and child health interventions in the country. However, funding gaps still remain. On coordination, there was a coordination gap in terms of bringing together the multiple sectors that need to address pneumonia. But more recently, the Every Breath Counts initiative has supported the government to pull diverse actors together to address this. And in 2017, they developed the National Pneumonia Control Strategy, which is a first, I believe, in the world. And then I'm going to come to that in my closing. And then finally, I want to highlight the accountability gap. We say that you measure what matters, and the data that's available helps you track how well you're doing. The data we have for pneumonia is really from DHS surveys that come every 5 years, or from mixed studies that come every 3 years. And sometimes they don't go down to the level that, the granular level, the subnational level where you need to know what is happening, where you need to track your progress. So the long interval between when we can assess how well we're doing in pneumonia control has actually hampered active improvement in the program. So the Saving 1 Million Life now instituted a National Nutrition and Health Survey, which they call the SMART survey, that produces estimates every year. So cutting down the long interval. And so with this data, we're able to keep track of how well we're doing on pneumonia. And then other interventions that have been put in place to really ramp up both the visibility of pneumonia control and the service delivery that's required is advocacy around World Pneumonia Day. That has really been, quite impactful. And then at the primary healthcare level, there's been the strengthening of the implementation of the primary health care under one roof. So reducing the fragmentation in service delivery. And then more recently, there's been in terms of funding, there's been the Basic Healthcare Provision Fund that provides funding directly to health facilities so that to ameliorate the funding barriers. And then finally, in terms of what Nigeria has done, to really bring together all the various pieces and forge forward is really the pneumonia control strategy. This was launched in Spain at the end of, I believe, at the end of January during the global symposium. And what this really has called for is to strengthen coordination, particularly among national bodies, the federal and state government. Let them all get involved in pneumonia prevention. Civil society have a role to play, the private sector have a role to play. And then we also need to make sure that the funding from WHO, UNICEF, Gates Foundation, Gavi, Global Funds, they are all very well coordinated and feed into this one plan. So we really should be rowing from the same boat, and the National Pneumonia Control Strategy should be the guide that every partner should feed into. And because it has everything, it has the targets, it has the costed plan, it has the operational requirements to ensure this multi-sectoral collaboration to reduce pneumonia mortality in the country. And then finally, the issue of data again has to be re-emphasized, that we need data to show us how well we are progressing. So with that, I think that's the end of my presentation. Thank you very much.
Thank you very much, Dr. Wunodi, and thank you for what we've learned of what is happening in Nigeria. We have spoken about how is the burden of the disease in countries all around the world. We know how is infravalorated the importance of this disease, but also that we have not a lot of money to invest in research until we have COVID-19 this year. However, we can prevent this disease. How can we prevent this disease? We can do that by preventing with the use of vaccines. And we have to extend the programs of vaccination all around the world. And for that, we have the Senior Program Manager of the Vaccine Alliance, and Dr. Veronica Denti will explain us about how can we do that around the world. Thank you, Dr. Denti.
Thank you so much. I'm not a doctor, but still super privileged to be here and to follow such a distinguished panel of doctors indeed, and to represent Gavi, an organization that I'm most honored to work for, and particularly to give you an overview of a decade of indeed what is possible when the resources are there. And I hope you can all hear me clearly and see the slides clearly. Can you hear me okay?
Yes, we can hear you.
Good,
Doctor.
Just checking in. So let me show you a slide that hopefully will bring some encouragement, particularly following some of the information that you've seen from Dr. Sinley's as well as from Lee's from Every Breath Counts. So immunization coverage, out of all the indicators that one can look at to measure how we are combating the war against pneumonia and how we can prevent pneumonia, this is the best performing indicator. And yet, you will see in this presentation, so much has been achieved in a decade, and yet so much is yet to do. So Gavi has been supporting pneumonia since 2009. Since then, 60 out of the 73 Gavi countries have introduced pneumonia vaccination in routine, meaning they're routinely vaccinated all their children, funded by Gavi and funded by the country's government. And all of these children amount to more than 215 million children in low and middle income countries in the world in the past decade. And this converts to more than 500,000 deaths estimated to have been prevented thanks to this effort. And this has reached almost half the children that should be vaccinated with pneumococcal. In Gavi countries, that percentage is 49%, which is 1% above the global average that Leith had shown. And it's a great, great achievement, but that still leaves more than half to reach. And all of this has been achieved through procuring last year more than 161 million doses. At roughly $3 a dose, that gives you a measure of Gavi's investment every year is more than $500 million to achieve these results. But of course, as you can see, I'd like to see the same slide that Dr. Silonis has presented earlier, but this is a different version of it. This is a version that only focuses on Gavi countries. The good news is a lot of it is green, meaning they have introduced in routine. The other good news is that the countries that were shown to have the highest burden of disease in children, which are namely Nigeria, India, Pakistan, Ethiopia, and also the Democratic Republic of the Congo, they all have introduced pneumococcal vaccine in routine. And yet, because of the reach, there's still so much to do to reduce that number of deaths. We're also very encouraged that we have other countries on the line, Indonesia first and foremost, Timor-Leste, but also hopefully Ukraine, Tajikistan, that in the next couple of years should be introducing pneumococcal vaccine through Gavi support. How does this look like in terms of growth? I thought I would give you an overview of countries, of children, and of coverage. And you've seen that this curve has grown immensely with a boost of countries first, and the final thread, you see the number of children growing really much and the number of countries not so much. Well, that's mostly because of India. When India joined and has scaled up, and a lot of their scale up is still due. So you've seen a huge growth, and yet we're still only at 49%. It is super encouraging to show what is possible when the resources and the political will and the partnership all align, and shows how much is still necessary to be done. Now, how was this achieved? The Gavi model typically focuses on a co-funding between countries and Gavi, where Gavi takes the lion's share for countries that are weaker from a sustainability financial perspective, and that over time that grows. And this is what we call on the demand side that you see on the slide here. We fund the vaccines, but that's not sufficient. We also need to fund health system strengthening. We need to fund technical support, technical assistance. So we fund a lot of partners, you'll see them in a moment, to help countries have the human expertise and bandwidth, because typically it's more of a bandwidth issue, to dedicate to prepare the introduction and to keep it running and monitor how it goes and course correct over time. But for pneumococcal specifically, that was not enough. In 2009, some visionary colleagues of mine put together the Advanced Market Commitment, which was started as a test pilot. And it was put together to provide some financial backing to demand. Because without that, manufacturers would not have scaled up production to a level that was needed for us to have more than 150 million doses to buy every year. So there had to be a financial backing to create confidence for manufacturers to invest and for countries to invest, knowing that with the volume going up, the price would go down. But not only that, you also needed the whole alliance coming together. You've seen the donor front, the World Bank front. Those were the founding partners of the advanced market commitment, but without the implementation support that we get all the time from the WHO at global, regional, and country level, from UNICEF supply division as well as the program division, from CDC that gives us the technical expertise, most recently to help countries assess what schedule is best. Should they give 2 doses plus 1 at the end? Should they give 3 doses regularly? This is where countries need to be supported in assessing their options. And I'm so grateful that I can work with these group of partners that also include IVAC, that include CHAI, and I also want to mention PATH, because they created a tool most recently to assess the cost difference with all the new options that are now available. You've heard the Serum Institute of India vaccine being mentioned earlier on in a couple of presentations. That is the cheapest pneumococcal vaccine now available. But how can countries compare among the option that they are on today and the option that they might consider to switch to? And the tool that PATH just created makes it a lot simpler for them. Talking about price. This is probably the graph that I love the most to really show the Gavi impact over time. You see a volume of procurement that goes up. The blue bars are the number of doses that are bought every year. And then you see the green and the blue lines that are the prices of the 2 main vaccines that we were able to procure through the advanced market commitment and through the support of UNICEF supply division every year until, and we continue to be able to do it for the next decade, hopefully. But there's a newcomer that made it to reduce the price by 30% on $3 a dose. That is immense for the cost of a vaccine specifically, because the volume of that is massive. That has been made available as of 2020 through the Gavi mechanism, through the UNICEF mechanism. We have Uzbekistan, that is the first country that has benefited from it. We have Timor-Leste that already requested it for 2022. And there's a number of other countries that are starting to consider and propose a request for that to us. What this means is that we're finally able to diversify the offers in terms of options that countries can have. Suppliers that they know and are familiar and trust with, new suppliers with a difference in cost, multi-dose vials, single-dose vials, and this variety came through the advanced market commitment. Now, a question probably on many people's mind is the disruption caused by COVID-19 on PCV vaccination. And here I can only give you mostly anecdotal evidence on top of what you've probably read already from the WHO Pulse survey that looked at Q2 data, so May to June, and it looked not at pneumococcal specifically, but it looked across routine immunization, and it really diagnosed a lot of disruption. This is across all the countries, not just Gavi countries, but they've seen massive disruption, particularly in Africa, the African continent and the Southeastern Asian continent, particularly for outreach, which are the ones that go and reach the communities that are hardest to reach out there, where the most vulnerable children are. So there needs to be a renewed effort through this crisis to maintain and restore and strengthen immunization. And I'll show in a slide in a moment. But from a demand perspective, that is only one aspect of the risk that COVID-19 has posed to pneumococcal vaccination, because suppliers are also facing risk. They have facilities in countries that are affected by lockdown, and they need to make additional efforts to keep those facilities clear and operating with people showing up for work despite the lockdowns around. There's also been disruptions to flights everywhere, and flights is how vaccines are shipped. So for UNICEF Supply Division, it's been a hell of a year to try and make sure that all the shipments that were planned, despite being delayed, could get to the countries to avoid stockouts. So it is a massive, massive lift to keep up all the gains that you've seen have been achieved for the past decade. I have one last slide to share. And it's a slide looking ahead for the next 5 years of what we call the Gavi 5.0. It's one of our brand names for our strategic period. What do we want to achieve? And the board of Gavi has just reprioritized our goals. They are to really maintain and restore and strengthen immunization, including catching up on all the children that have missed through these gaps in immunization that was recent. Reach the children that are not yet reached. And I'm one of the many panelists today to say the same message. We've achieved a lot, but there's so much left, particularly for pneumonia. The risk is immense. These children need to be found. They need to be protected through vaccines and all the other measures. And finally, there are countries that in January at the Global Pneumonia Forum have made a massive declaration of political will. These were Somalia, it was Chad, there were other more. And we want to keep supporting them to match their political will with resources to make sure that we can close and narrow this gap as much as possible in the next 5 years. And the goal for that is to avert 700,000 deaths, a massive number. Thank you so much.
Thank you so much, Veronica, for your excellent presentation. We are going to pass through the next part of the symposium today. Researchers are really worried about the funding on the teams of pneumonia. Because pneumonia has been, in the past several years, a neglected disease. Since we have now COVID-19, some of the organizations around the world have tackled this issue by funding giving money to do some research on pneumonia caused by COVID-19. However, we have today the presidents from several scientific societies. And our next speaker is Professor Juan Celedón, which is the Niels K. Jern Professor of Pediatrics and Medicine and the Chief of the Division of Pediatric Pulmonary Medicine at the University of Pittsburgh in the United States, and is now the president of the American Thoracic Society. I will give him the time to give us his speech. Thank you, Professor Celedón, to be with us today.
Yeah, I'm sorry, I had sent you a pre-recorded video. I sent that to Dr. Sionis.
We can see, I think we can see your video first. Can we? Let us give us 1 minute.
Thanks. Good afternoon. It's truly a pleasure to accompany you at this global conference on World Pneumonia Day to highlight a very important public health issue. My name is Juan Carlos Celedón Ginás, and I'm the caring president of the American Thoracic Society, ATS, and it's truly a pleasure to represent the ATS at this event. I have received research materials from PharmaBite, GSK, and Merck in order to provide medications free of cost to participants in NIH-funded studies. However, I have received no salary support from these companies, and I will not be discussing any commercial products in this presentation. So the mission of the American Thoracic Society is to improve health worldwide by advancing research, clinical care, and public health in respiratory disease, critical illness, and sleep disorders. Pneumonia as a cause of death in children under age 5 has decreased markedly over the last 30 years by about threefold. the Democratic Republic of Congo, deaths from childhood pneumonia in rate from pneumonia, as this map shows. Pneumonia is not a disease that is spreads easily across borders. Transmission is generally restricted to local communities.
Good afternoon.
Of course,
it's truly a pleasure to accompany you at this global conference on World Pneumonia Day to highlight a very important public health issue. My name is Juan Carlos Celedón Ginás, and I'm the caring president of the American Thoracic Society, ATS, and it's truly a pleasure to represent the ATS at this event. I have received research materials from childhood pneumonia. Good afternoon. It's truly a pleasure to accompany you at this global conference on World Pneumonia Day to highlight a very important public health issue. My name is Juan Carlos Celedón Ginás, and I'm the caring president of the American Thoracic Society, ATS, and it's truly a pleasure to represent the ATS at this event. It's truly a pleasure.
Some technical issues with Professor Saladon's video. Shall we go to our next speaker, or do we start with our...
No, wait a minute, please.
We will start again the video from Professor Saladon in 1 minute.
Compartir,
The ATS at this event.
Thank you so much for your patience.
Good afternoon.
This is like worldwide, so it's kind of complicated to do all the connections.
At this global conference on World Pneumonia Day to highlight a very important public health issue. My name is Juan Carlos Celedón Ginás, and I'm the caring president of the American Thoracic Society, ATS, and it's truly a pleasure to represent the ATS at this event. Public health issue. My name is Juan Carlos. I have received research materials from PharmaBuy, Thoracic Society, ATS, where to provide medication represent the ATS NIH-funded studies. However, I have received no salary support from these companies, and I will not be discussing any commercial products in this presentation. So the mission of the American Thoracic Society is to improve health worldwide by advancing research, clinical care, and public health in respiratory disease, critical illness, and sleep disorders.
Thank you so much for your patience.
Good afternoon.
This is like worldwide, so it's kind of complicated.
Pneumonia as a cause of death in children under age 5 has decreased markedly over the last 30 years by about threefold. This said, however, pneumonia is still, as of 2017, was the leading cause of death for children under the age of 5. The reason why we're seeing this reduced mortality from pneumonia to provide medication represent.
I think we're having troubles putting the video of Professor Saladon. So what we're going to do is to go through the next speaker, which is Professor Anita Simmons. She's Professor of Respiratory and Sleep Medicine at the National Heart and Lung Institute at the Imperial College London. Thank you very much, Professor Simmons, for being with us today. We will go back to Professor Saladon after your talk.
Thank you very much. Thank you. I will try to negotiate the technology, and I'm very grateful for the invitation. And I thank Katia in particular for her vision and for the smooth organization. Can you hear me okay? Can you hear me okay? If so, I will continue.
Yes, we can hear you.
That's great. And so I decided to focus on a very specific topic, and that is ventilatory strategies in pneumonia. And I have focused on COVID. I know there are other sessions later, but I hope some of these pieces of information can be extrapolated elsewhere. Our early lessons on ventilatory support in pneumonia, in COVID pneumonia, came of course from China, where it became clear how cases could be identified, prognostic factors, and also some of the radiological appearances, such as these posterolateral interstitial changes, and the fact that in this early study, it was possible to support individuals on non-invasive ventilation as well as invasive ventilation. And so that was an important lesson learned. As the situation moved to North Italy, there was increasing experience with using non-invasive ventilation, and we talked earlier about CPAP use in these patients, continuous positive airway pressure therapy, and also the use of proning, that is managing individuals with severe COVID pneumonia on their fronts to improve the oxygenation. And the combination of CPAP therapy here delivered through a helmet, but mask can be used too, and proning can have a very significant positive effect in oxygenation. And of course, these are relatively low cost interventions. And here you can see that the combination in this orange line here compared to, so this is CPAP and oxygen therapy compared to oxygen therapy alone, reduce the needs for intubation. And in this study, too, from Italy, where there was very severe pressure on intensive care unit beds, the use of CPAP seemed to salvage about a quarter of the patient's lives. And so it is a truly important low technology, relatively low technology intervention. And there have been a number of protocols developed and comparisons too of CPAP therapy with high flow nasal cannula therapy. Now this is high in demand on oxygen and is being used in the US and in Europe, but like CPAP therapy, it's a non-invasive approach, can be used outside the intensive care unit if there are no facilities available, and did seem to demonstrate the reduce in need for intubation compared to control groups who didn't receive it. What have we understood about the pathophysiology? Well, an awful lot, but in brief, just to mention some aspects. The initial hypoxemia, the low oxygen therapy, seem to be caused by a mixture of dead space and shunt, and this may progress to fibrosis in time. But not only do we see large thromboembolism, so macro thromboembolism, pulmonary emboli, deep venous thrombosis, a particular feature of COVID pneumonia is these microthrombi, probably immunogenically induced, which causes major gas exchange problems and of course can respond to anticoagulation. So that's a very important part of treatment. And this is just a schematic demonstrated from the beginning of the onset of severe pneumonia. There are various disputes about different kinds of phenotypes, but the lung compliance in the early stages is relatively low. But may increase over time if recovery doesn't occur. But we have these ranges of interventions from oxygen therapy to the non-invasive approaches with CPAP, non-invasive ventilation, high flow nasal cannula therapy, to invasive ventilation, or even ECMO if those facilities are available. Other interesting developments along the way is at the beginning of the pandemic, the feeling was that SARS-CoV-2 was transmitted largely by small droplets and by close contact and by fomites. But as the months have passed, it's become clear too, and is accepted by WHO, CDC, and other authorities, that there is at least an element of aerosol transmission, which may of course be influenced by a range of other situations such as environment, the general ventilation of that environment, and other factors too, and is partly why we use masks now and have a range of other strategies that we weren't using in some areas of the world at the beginning of the epidemic. There is concern with using some of these non-invasive approaches, such as CPAP, that they are aerosol generating and so add to risk for healthcare workers, and also may lead to super spreading events amongst patients. But this is relatively reassuring information from China, showing that where PPE or full protective equipment is available for healthcare workers, that the level of, and this is IgG and IgA antibodies, so evidence of infection, here in pink are the patients, and here are two comparator groups. These are frontline control healthcare workers, and these are frontline healthcare workers who were delivering aerosol generating procedures such as CPAP. But where the PPE was fully available, there was no significant difference between these groups, which is, as I say, relatively reassuring. What else? Well, there's been developments with treatments. I mentioned anticoagulation, information coming through from trials on antivirals, some conflict between the Solidarity study and some of the other studies, but many people now use remdesivir as a standard of care. But importantly, the recovery study has shown that dexamethasone, so relatively low-cost steroids, and that includes other steroids too, can be very effective at reducing mortality. And in severe COVID pneumonia in ventilated patients, there is a significant reduction in mortality from 41% to 29% with the use of dexamethasone. And of course, there are other trials in progress on a range of other interventions. So where are we? This is a schematic too of cases from the first wave, and then much more testing, so we see more cases detected. But there have been different patterns across different WHO regions. Here is infection in the Americas showing a gradual increase, too in Southeast Asia, but in Europe, the sort of classic biphasic appearance of the infections, with now in the second wave. There is some light at the end of the tunnel, although it may seem overwhelming at times, because with the combination of interventions mentioned and improved understanding, mortality has fallen. This is showing here outcome from severely ill COVID pneumonia patients, and this is survival here. And at the beginning, in the first wave, survival here in this study, you can see is at this level, but survival in the second wave, the current wave that we're in, has increased by around 20%. So this is encouraging. And there are a number of factors that one can attribute that to. We're better at identifying cases, so they're presenting earlier and managed better. It is possible, and some countries have done extremely well with track, trace, and self-isolation. There is improved treatment because of better understanding. There's better logistics and better planning. And I don't think, although we have evidence of mutations in mink reservoir at the moment, moving back to humans, no evidence of major changes in virulence at present. And so difficult situation, but progress has been made. And with that, I'd like to thank everyone again and wish you well with the Congress.
Thank you so much, Professor Simmons, and thank you for doing an excellent summary of what we learned in the past 8 months on ventilation in patients with COVID-19. We're going back to hear Professor Celadon's video. Sorry, we're having some technical problems. The fact of having this all around the world makes it a little bit complicated for us, but I think we can tackle it. Can we start the video from Professor Celadon?
It's truly a pleasure to accompany you at this global conference on World Pneumonia Day to highlight a very important public health issue. My name is Juan Carlos Celadon Ginás, and I'm the caring president of the American Thoracic Society, ATS, And it's truly a pleasure to represent the ATS at this event.
I'd like to thank everyone again and wish you well.
I have received research materials from Pharmabite, GSK, and Merck in order to provide medications free of cost to participants in NIH-funded studies. However, I have received no salary support from these companies, and I will not be discussing any commercial products in this presentation.
Professor Celadon's video.
So the mission of the American Thoracic Society is to improve health worldwide by advancing research, clinical care, and public health in respiratory disease, critical illness, and sleep disorders.
The video from Professor Celadon.
It's a truly pleasure. Pneumonia as a cause of death in children under age 5 has decreased markedly over the last 30 years by about threefold. This said, however, pneumonia is still, as of 2017, was the leading cause of death for children under the age of 5. The reason why we're seeing this reduced mortality from pneumonia in young children is multifactorial, and it has to do with having addressed some risk factors such as poor nutrition, air pollution, poor sanitation, as well as better availability of resources such as pneumococcal vaccine and antibiotics. Clinical care and public. However, as I said, still an important cause of death in young children, and more than 800,000 children died from pneumonia in 2007. Death in children under age 5 now has decreased. This map shows, the map on the left panel, the number of child deaths due to pneumonia per 100,000 children per year. And what this shows is that children are most likely to die from pneumonia across sub-Saharan Africa and South Asia. In fact, deaths in just 5 countries, including India, Pakistan, Nigeria, the Democratic Republic of Congo, and Ethiopia, accounted for more than half of all deaths from childhood pneumonia in 2017. It is for this reason that some colleagues have called pneumonia the ultimate disease of poverty. However, there is a very strong correlation between a country's income and the child mortality rate from pneumonia, as this map shows. Pneumonia is not a disease that is spreads easily across borders. Transmission is generally restricted to local communities, and of course, it can be controlled if basic health measures are available. Again, the disease is more common in places where poverty is common, healthcare infrastructure and resources are lacking. Here, we'll look at the risk factors for childhood pneumonia as of 2017. The most important risk factor is child wasting, which refers to a severe form of malnutrition where children have a weight that is too low for their height. In addition to child wasting, there are other risk factors such as indoor air pollution from solid fuels, outdoor air pollution, shore gestation for birth weight, child stunting, again underweight, poor sanitation, no access to hand washing facility, secondhand smoke, non-exclusive breastfeeding, which affects nutrition in young children, and vitamin A and zinc deficiencies. Health measures are available. This graph shows pneumonia mortality rates by age for a period extended from 1990 to 2017. And again, this shows the same data as in a prior slide, where deaths from pneumonia in young children under the age of 5 have been reduced by threefold. However, we don't see such reductions in other age groups. In fact, for the group with the highest mortality from pneumonia, who are people who are 17 years of age and older, mortality has only decreased by 9% over this 27-year period. These are data for the US. So between early February and early October of 2020, we had about 200,499 deaths that were primarily attributed to COVID-19. Now, there is another group of 320,143 deaths from pneumonia that supposedly also coexisted with influenza or COVID-19. So a major proportion of all deaths during this period, early February to early October 2020, which total up to 2.1 million. However,
Ricky. So we are going forward to our next speaker, which is Professor Jesus Rodriguez Baño. Professor Rodriguez Baño is a past president of the European Society of Clinical Microbiology. He's here in Spain, he's in Seville, and he's a full professor of the Department of Medicine at the University of Seville and head of the Infectious Disease Service at the Virgen Macarena University Hospital. Can you hear us, Professor Rodriguez Baño?
Yes, hello. Can you?
Oops.
Yeah.
Microphone issue.
Thank you very much. I will share my presentation. Okay. So I hope you can, let me just check it. So thank you very much on behalf of the European Society of Clinical Microbiology and Infectious Diseases. It's a big pleasure to participate in this very nice symposia. What I will do is that I will just give some information about how our society would like to work and collaborate in this very important field. One aspect, of course, in our society is microbiological diagnosis. You know, we are a society which includes clinical microbiologists and infectious diseases, besides some other colleagues from very different specialties. I know that Jordi Vila will be speaking later about diagnosis, but this is a very important aspect, of course, for us. And I think we are living a revolution in the etiological diagnosis of infections in general and in respiratory tract infection in particular. And of course, we have the classic methods that provide the etiological diagnosis no more than 30–40% of cases of community-acquired pneumonia and a lower percentage of cases with hospital-acquired pneumonia. But the molecular methods and similar methods have really came to stay and to be developed, and they are improving very significantly the possibility to diagnose other etiologies of infection like atypicals or viruses and in real time. So this is really a revolution for the knowledge of what is happening to our patients, also for management. And of course, some of the experience with the COVID-19 is a good example of that, but not only for this infection. There are still many questions to be solved here, whether the detected pathogens are all, the causative of the infection or whether they are bystanders, which is the clinical applicability of the different methods that are being developed, what is their cost effectiveness, and how to apply them to nosocomial infection, particularly in non-ventilator-associated pneumonia, in which diagnosis is frequently more difficult. And this is a very nice area for research. A critical aspect, of course, and there is some comment before in some of the previous presentation about antimicrobial resistance, and of course you all know that is a very important aspect to consider. And of course, our society works heavily on that from many perspectives that I will summarize in a minute, and that impact clearly patients with healthcare-associated nosocomial pneumonia, particularly in ICU, but not only, but also is increasingly important in patients with community-acquired pneumonia as well. And because of that, antibiotic stewardship is one of the activities that infectious diseases physicians have taken as one of their main tasks over the last years. And the reason for that is that, as you perfectly know, the use of antibiotics can be improved in many occasions. And therefore, this is an area in which we all have together to work to improve it. Particularly, respiratory tract infections are a frequent source of inadequate use of antibiotics, as we all know. In all studies in which we evaluate the use of antibiotics, because of the frequency of this type of infections, it's also frequent that the antibiotic use can be improved, and there's room for improvement. From the use of monotherapy versus combinations, to how do we do with the spectrum of the antibiotics in empirical therapy or in targeted therapy, when we can de-escalate the duration of treatment and switch to oral therapy whenever is possible, are really critical, a very important aspect to consider. A subset of patients that we frequently have to deal with other colleagues are immunocompromised patients for different reasons, for HIV infection, which unfortunately is less frequent now, but transplant patients being treated with biologicals and other immunosuppressants are increasingly steadily, and this is a huge challenge for all of us. These populations are very heterogeneous, and there is a wide range of potential pathogens affecting them, depending on the type of immunosuppression, the epidemiological context in which the infection occurs, the clinical context of specific patients. So complexity in diagnosis and treatment is really an issue in this population, where we need research, we need to implement guidance and guidelines. And finally, of course, prevention. Prevention is a critical aspect, not only for vaccines, but also for transmission aspect, environmental aspect, and any other aspect, reducing the risk of infection in general and respiratory tract infection in particular. So ESCMID has what we call two committees. One is the European Committee on Antimicrobial Susceptibility Testing, that, as you know, is providing recommendations for the testing and the interpretation of the tests for antimicrobial resistance, and is working together also with other society and medical specialists to try to improve the way we provide that information, and also trying to accelerate all processes, but providing very reliable data. And the other committee is a committee on infection control, in which we are working, trying to reduce the burden of infection in general, and antibiotic resistance in particular, and of course, respiratory tract infection in general and pneumonia is one of the biggest aspects to work with, and we're trying to homogenize how we do that in European countries and all over the world. ESCMID has 31 study groups. Many of them have activities related with pneumonia because of their different perspective and focus of infection. And this group forms thematic networks for research, for education, training, and networking, which are very active, and everyone is invited to participate. Of course, our journal, which is one of the top journals in the field of clinical microbiology and infectious diseases, provides research information and our guidelines. And of course, our meetings, either small meetings or bigger meetings like the one that we have on ECVID recently, which is still available for online consultation, and the next ECMID, are of course minor activities in which we can network and discuss and develop new activities. So our approach has to do with professional affairs in education and training of our colleagues. We are also doing some other activities with other European society like ERS and others. Within the healthcare system, we promote evidence-based multidisciplinary approach for the management of this patient. Within that, the complexity of community-acquired and hospital-acquired pneumonia makes it very appropriate to work in multidisciplinary groups and with other colleagues from different medical specialties. And in that way, we think we can improve much better the outcome of patients and the preventive measures. Of course, guidelines and guidance are key aspects in our activities. Of course, research project and advocacy, trying to convince policymakers to increase research funds in this area that has been explained before by other colleagues is really a very important issue. That was all. Thank you very much. And we were very happy to participate and also very happy to collaborate with other society in this field. Thank you very much.
Thank you. Thank you very much, Professor Rodriguez Baño, for your excellent talk. We have faced what is the position of the society in this field. And we have now, we will move forward to our fourth speaker today. We count with the presence of Professor Kit Klugman. Kit Klugman is the director of the Pneumonia program of the Bill and Melinda Gates Foundation. He is the director of this program, and he leads in this foundation to work to reduce deaths from pneumonia, neonatal sepsis, and also meningitis. Thank you so much, Professor Klugman, for being with us today.
Well, thank you very much. And I must say it's a great pleasure. I have a sort of strange title to be the Director of Pneumonia, but it's really the Director of Pneumonia Prevention at the Gates Foundation. And it's a particular pleasure to have been invited by this group in Barcelona. It takes me back many years to the early 1980s when at international infectious disease meetings, just about the only people talking about pneumococcal pneumonia were people from Barcelona, Dr. Payares and Fila Linares and myself from South Africa. So it's a great pleasure to see the way that Katia has mobilized support globally to focus on the burden of pneumonia mortality as a neglected disease in children. So this is a really important slide. Many of the things I say were said earlier by Leith and Kike, but I want to link the reduction in pneumococcal pneumonia, in fact, the reduction in all-cause pneumonia in children, to the rise in pneumonia in adults. And this is particularly pertinent now for COVID. So we have seen over the last 27 years since 1990, a dramatic reduction in pneumonia mortality in children. You'll see the reductions in green in all the age groups in children, but at the same time, an increase in pneumonia in the elderly. And this is in fact a reflection of something good that is happening, and that is the rollout of vaccines to prevent pneumonia in children, as well as improved nutrition in children. So many of the underlying causes of pneumonia deaths in children that have been discussed have been addressed. But it also reflects the fact that people in many countries are living to older age groups. And you see on the right-hand side that for those over age 70, there's been a doubling in pneumonia mortality. Now, this slide is before COVID. And of course, the COVID deaths are massively situated in the over 70-year-old age group. So for those of us in the pneumonia field, it is not new to recognize that the elderly are at particular susceptibility from pneumonia, as well as the very young. And this is the U-shaped curve that Leith alluded to. When we look at pneumonia in children, however, there is something also very concerning emerging, and that is when you look at this pie of all the causes of death in children, pneumonia is way up there. You'll see that there's 12% of pneumonia deaths above the neonatal period, another 3% in the neonatal period. But all the yellow in this slide is deaths in children in the first month of life. So what is happening over time is that the fraction of child mortality is being increasingly concentrated in the first month of life. And so at the Gates Foundation, where our primary mission is to reduce mortality in children, we're increasingly looking not only at pneumonia, but at neonatal sepsis as well, which is a major cause of that mortality. And so my talk today, I'm going to focus on vaccines to prevent these deaths. And there's some very exciting potential new vaccines that I will mention that haven't come up so far in the discussion, which we hope will become available, particularly to prevent early pneumonia deaths in the first few months of life. Now this I'll just briefly show because it fits with some of the previous talks, and just to highlight that depending where you are in the world, different age groups suffer predominantly from pneumonia. Leith talked about the countries that suffer both from pneumonia in children and adults, but you'll see that's true in South Asia. In Africa, still the majority of deaths from pneumonia are in children. And if you move to Europe, high-income countries, you do not see the blue at all. So the big burden of pneumonia mortality is in the elderly. I won't dwell on this because this has been shown that in those poor countries, only 5 countries now are responsible for more than half of the pneumonia deaths, and they're illustrated in dark blue here: India, Pakistan, Ethiopia, the DRC, and Nigeria. So the best way to prevent these deaths is with vaccines. We have vaccines, as we've heard, against the pneumococcus, against Haemophilus type B. We do have flu vaccines, and unfortunately they're either too expensive or not effective enough to prevent significant burden of pneumonia in young children. There's a little bit of work being done to give influenza vaccine to pregnant women that I'll discuss. But there are 2 other major causes of pneumonia on the slide that haven't been discussed at all. The first and most important, in fact, in young children under 6 months of age is RSV, the respiratory syncytial virus. Some very exciting opportunities now published only in the last couple of months to prevent RSV in young children. And then the leading cause of death on the first day of life from infection is actually the group B streptococcus. And that too, there could be a vaccine made, and it's something that we're trying to support. When we look at the vaccine preventable causes of pneumonia, it is quite clear, in fact, that the pneumococcus is the leading vaccine preventable cause of pneumonia mortality. You do see Hib here, and you see influenza on the right-hand side. And then there's been quite a lot of discussion, so I'll go quickly through this. This is basically showing you that the majority of those deaths, as we've heard, are in Africa. And the big problem, as well as the good news. So the good news, as was pointed out by Gavi, is that 10 years ago, no developing countries had PCV at all. Now there is a map filled with varying degrees of coverage of PCV, but still some major gaps. Large countries in Africa, such as Nigeria and DRC, Angola, with large populations, where there is insufficient coverage of PCV. India, which has just started rolling out the vaccine, much of the country hasn't rolled out yet. And Indonesia, where the vaccine also is hoped to roll out in the next year or 2. So we expect the coverage to dramatically increase. There is something called a middle income gap. You heard from Gavi the remarkable news. This is something that, in fact, the Gates Foundation funded, the development of a $2 dose of PCV made in a developing country in India. This is very exciting to bring down the cost of PCV. But in fact, the middle income countries are a particular problem. And you'll see there, particularly for a European meeting, this large area in Eastern Europe where there is no vaccine because it's not affordable. So we are optimistic that the cheaper vaccine may fill that gap. To finish then, I want to talk about the bottom line here, which is this red line showing relatively modest gains in reduction in neonatal mortality. I did mention that maternal flu vaccine has some potential, but in fact, the burden of flu mortality is not, in fact, in the first 3 months of life, when this vaccine can be effective if it's given to women. And there are no vaccines at the moment that are licensed to be given to children under 6 months of age for influenza. So what about RSV? I mentioned RSV earlier. There was a very exciting monoclonal antibody developed. It's on the slide. It's called nirsevimab, which was published just earlier this year to show 70% or better protection of young infants when given in the first few months of life. Monoclonal antibodies are expensive, but one of the overarching themes of this pneumonia meeting in the middle of COVID is that COVID is doing terrible things, but at the same time, we should not lose the opportunity of COVID to make significant gains for preventing other causes of pneumonia. And the rapid development of COVID monoclonals, their demonstration of efficacy if given early enough, will transform the landscape for monoclonals. The Gates Foundation is at its own risk funding a massive roll-up of Eli Lilly monoclonal to be used in the developing world. And we are optimistic, especially for very small babies that of course need a tiny fraction of the amount of monoclonal needed to prevent COVID in adults, that in fact these could be affordable. So there are two approaches to RSV. One is the monoclonal given to young babies. The second is that there are now, there's a phase 3 trial going. It's a second phase 3 trial of a RSV vaccine given to pregnant women, and we're hopeful that it will have similar high levels of effectiveness in preventing RSV in babies in the first few months of life. Briefly mentioned Group B strep. Here, the vaccines have not yet reached phase 3, but there's low-hanging fruit to make a conjugate vaccine to immunize pregnant women. We also believe that in fact GBS is responsible for stillbirths in addition to the pneumonia burden. To finish up, a number of people have alluded to the problems of oxygen delivery. And again, this is an area where we think that progress and funding for COVID could help with the delivery of oxygen in poor countries. So to summarize then, focusing on the most prevalent cause of pneumonia, at the Gates Foundation, we're very excited that we have vaccines that are available or in development for the majority of pneumonia pathogens. We greatly applaud the efforts of the folk organizing this meeting to try and focus the world's attention currently on a new cause of pneumonia from COVID to address the major burden of pneumonia in children in the developing world. So thank you for your attention.
Thank you so much for your excellent presentation, Professor. We are going to move to part 2 of the symposium. We will talk about what is the future of the pneumonia awareness. We know that we have to treat, we know that we have to talk about the disease, and we know that we have to talk about the disease, but not only from the European or the American point of view, but also to treat this disease not in isolation. And for that, we have 3 speakers today. The first is Dr. Louis Pearson. Dr. Louis Pearson is the Acting Associate Director and Chief of the Health Program of the UNICEF, which is the United Nations International Children Emergency Fund. In this role, she provides strategic leadership to management support and the overall direction of the UNICEF Global Health Program. And I'm very thankful for her to be here with us today. Thank you, Professor Pearson.
Thank you. Thank you for the opportunity to invite me to speak on behalf of UNICEF. I hope you can all see my presentation. And I have learned a lot from the previous speakers. From UNICEF, I'd like to really focus on the program elements of what you all talked about, the pneumonia, the burden, the situation. UNICEF works in more than 100 countries, especially the countries with high burden of pneumonia. We looked at the current situation with pneumonia treatment since COVID by comparing Q2 19 and the Q2 20 data on many care seeking of pneumonia. We have seen a reduction of care seeking in all countries. We could get hold of the data from the health management information system. As bad as 3/4 in Bangladesh reported by the government due to severe lockdown to less affected.
I think we're having some
That's
technical
significant
issues.
reduction in DRC, Afghan of keeping an eye. Sorry?
Sorry, Professor, I think we have trouble with your audio.
Oh, you can't hear me?
Now we can hear you. Okay.
All right. Shall I repeat what I said in the last 30 seconds? That in the world, we have observed a reduction pattern of pneumonia care seeking in all the countries we can get hold of data. And we need to really tackle the situation, especially in those countries that have reported very severe reduction of pneumonia care seeking. Bangladesh, Nepal, Kenya, Pakistan, you can see the names of this country. Interestingly, in 2018, in northern part of Nigeria, we also documented a much increased mortality among children with severe malnutrition if they also present cold infections, either pneumonia, malaria, and diarrhea. Just remind us the importance of tackling the common conditions together. And today I want to present the idea of a creation of my colleagues, Anna, Rory, and others, on an idea called the pneumonia wheel. That is to look at the different aspects of pneumonia around the disease, the different contributing factors and the system factors. You have spoken about immunization, the IMCI, ICCM, and the importance of linking prevention and the primary health care level treatment with referral facilities for severe cases, the importance of air quality, pollution, and nutrition, and community engagement and accountability. We are also adding water and sanitation to this currently. It just tells us that we need to look at country by country how the different kind of interventions related to pneumonia have different kind of coverage, where the gaps are, and we should have a holistic program approach to deal with the condition. This is the pneumonia pathway, and from identification to treatment at primary health care facilities and to referral, and more lately, the linkage with quality of care, including oxygen therapy. The COVID-19 presented both a challenge as well as opportunities to highlight what we do is important, and our investment to health systems in nutrition, in oxygen, in wash have paid back in many settings to reduce mortality and prevent the disease. The number, 4.2 million children that are deprived of oxygen in low and middle income countries, is an interesting figure. And the Nigeria presentation from earlier speakers, and many of you have already spoken to the importance of primary health care, and I will not repeat your point, just to say that we acknowledge the huge burden of a huge gap of lack of oxygen to provide quality of care. That is why UNICEF, in collaboration with the pneumonia with the many treatment consortium, including WHO's leadership, we distributed nearly 30,000 set of oxygen concentrators throughout the world since the onset of COVID-19. We're really happy that this gives the opportunity to make oxygen therapy a reality. And we need to beef up local production and the local capacity instead of just throwing in more concentrators. These are two pictures from Bangladesh to show our effort getting oxygen in for both the production as well as treatment. And from UNICEF's point of view, we want to, again, focus on the multi-sectoral programming, pneumonia-specific and pneumonia-sensitive programs. Again, I want to thank all of you for this opportunity and your collaboration with UNICEF at the global and the country level. Thank you.
Thank you so much, Professor Parsons, for your excellent talk today. We are going to move forward. Our next speaker we will hear the talk from Anshu Banerjee, which is the Director of the Maternal, Newborn, Child and Adolescent Health and Aging from the World Health Organization. Thank you so much to Dr. Anshu for being with us today.
Thank you very much, and it's a pleasure to be part of this conference today, and a wonderful opportunity to sort of try to complement, I think, a lot of the previous speakers. I'll share some slides which are maybe pretty similar, but I hope that I'll be able to give a slight different angle to it or highlight similar points from a slightly different perspective. And so, as has already been shown, we know that we have 5.2 million deaths under 5, but pneumonia is the biggest killer among those, so 834,000 deaths. And we know that around 80% of those take place in sub-Saharan Africa or in Southeast Asia. But just to show here that pneumonia plays a proportion of deaths in many of the different regions across the different age groups. So whether it's amongst children 1 to 11 months or 1 to 4 years or 5 to 9 years, even in all the different regions, we see that the green component here, the dark green component, still plays a major role in child deaths. At the same time, we know that the rates, the age-specific pneumonia deaths by rates is different by the regions. We have also seen that in other slides. But if we look at the number of children that die of pneumonia in the African region, in low-income countries, compared to some of the other regions, even though they are low, middle-income countries in other regions, it's much higher. So in low-income countries in Africa, the death rate is higher than in low-income countries in, for example, the European region or in the American region. And of course, then if we compare it to high-income countries, it's of course even much higher. However, just to show that the overall number of deaths are still, for example, in Southeast Asia higher than in the Eastern Mediterranean region, even though there the rate is higher. Now, if we look at service utilization, we have seen where most of the countries, where most of the deaths take place, but we also see that, of course, that correlates very much with universal health coverage. And so in the regions where we have lower universal health coverage, this is also where we have much higher pneumonia mortality. Number of cases, however, there has been progress, has reduced from 28 million in 2000 to 22 million in 2015 due to early identification and treatment of non-severe cases. And at the same time, we have also seen that the number of admissions has increased. So definitely there is an improvement in access to treatment for pneumonia. And at the same time, we also have equity issues. And so if we look at, for example, improved sanitation, we see that amongst the quintiles, access to improved sanitation varies very differently or very largely between the different quintiles. But for care seeking for pneumonia, this is also the case. And so between the different quintiles, we see that it can range between 60 to 80% of care seeking behavior. What has been done? So there was the Ending Preventable Child Death and Pneumonia from Pneumonia and Diarrhea action plan that was set up and to be achieved by 2025. And it really looked like at an integrated framework that looked at 3 areas: protect, prevent, and treat. And so under protection, we had issues like exclusive breastfeeding for 6 months, for children under 6 months, adequate complementary feeding and vitamin A, sorry, I don't know why this is happening, and vitamin A supplementation. When we look at prevention issues that have been highlighted, it's around vaccination, but it's also around access to wash and hand washing. It's around air pollution as well. And when we come to treat, it's really about increasing improved care seeking and referral, case management at the facility, as well as continued feeding, including breastfeeding. So really the issue about the topic that, we should not look at pneumonia treatment in isolation is really highlighted there. And as Lu has just shown, we came up with this framework to sort of maybe articulate that a little bit better on how this multisectorality plays a role. So now looking at what's happening at country level, we sort of looked at, do countries have actually policies in place to manage childhood pneumonia? And on the left side, the blue bars are for children up to 5 years. And on the right side, the more orange colored bars are for children between 5 to 9 years, to look at whether countries had policies in place. And of the countries reporting, we see that there is a wide variation, but overall, it doesn't look like the right policies are in place to support pneumonia management, whether it's prevention, diagnosis, treatment. The other thing already highlighted in that wheel was the issue of clean air. We know that air pollution results in around 570,000 child deaths a year. And that looking at this slide, the dark blue is where air pollution is above WHO guidelines, above accepted levels. And we can see that in the countries where we have highest number of deaths, these are also the countries where we have actually quite high air pollution. The other issue that's important to look at is, where are the children taken to for treatment and what kind of treatment do they get? So the left graph here shows that healthcare seeking, whether it's at the first level facility or at a referral level facility, varies between the different regions. And at the same time, whether whether countries are providing amoxicillin as a first-line treatment also varies. So in some regions, let's say amoxicillin as a first-line treatment for chest indrawing and for breathing pneumonia is in place. In others, it's less so. So there is still a wide variety in making antibiotics accessible through clinical guidelines for pneumonia with fast breathing or chest indrawing. And so one of the things that we have looked at is to say, what kind of treatment mechanisms should we put in place and where should it be provided? And so looking at the first 59 days, in principle, our recommendation is that children should be referred to the healthcare facility. And if there are danger signs, or if it is in a child less than 7 days old, the child should be referred to hospital for inpatient treatment. But otherwise, if it is a child between 7 and 59 days old, we can have a confirmation of the pneumonia at the healthcare facility and treat it with oral amoxicillin. For children between 2 and 59 months old, there where there are danger signs, we recommend that the child is referred to a hospital for inpatient treatment. But there where it's only fast breathing, we say that the child can be treated at the community level with amoxicillin. And if there are chest indrawings, we recommend that the child needs to be referred for diagnosis at the health facility level and to be treated with amoxicillin. However, we are looking, because one of the things that Quique highlighted at the beginning was to say, can we look at different kind of treatment strategies? So at the moment, we are looking at whether community health workers actually can treat pneumonia with oral amoxicillin at the community level for children between 7 and 59 days with fast breathing, or for children between 2 and 59 months with chest indrawing. And we hope that we'll be able to have those results out in the near future in order to be able to see whether we can provide treatment one level further down at the community level. Just adding to the discussion on COVID, we have seen that indeed we have had disruption of services for sick child health-seeking behavior, and up to 51%. So definitely the COVID pandemic has resulted in disruptions for pneumonia care-seeking behavior as well. And the guidance that has come out has really been around making sure that acute child care is still being provided, but with additional appropriate IPC measures and PPE for healthcare workers, both for healthcare workers at the community as well at the facility level. And as a final slide, just to highlight a few points as the way forward, there's the need to improve diagnostics. So looking at, for example, point of care diagnostic tests, as well as trying to be able to distinguish between viral and bacterial pneumonia, is to look at how to improve or increase coverage of pneumonia treatment, including timely care seeking behavior, early identification, prompt treatment, as well as access to devices such as Quique also mentioned, I think early on in his presentation, such as timers, pulse oximeters, oxygen, etc. But also to look at this holistic multi-sectoral action that would support in, improvements within the education sector, environmental sectors and nutrition sectors as well. And finally, to sustain essential services in order to, by identifying and interventions to sustain essential health services, as well as to improve pneumonia management during the COVID pandemic. Thank you very much.
Thank you very much, Professor Van Gier, for your presentation. It was really nice to see how all the organizations are tackling the impact of pneumonia all around the world. Our next speaker is Kevin Watkins. Kevin Watkins is the Executive Chief of Save the Children, the organization. He was, before joining Save the Children, he was the Executive Director of the Overseas Development Institute. So now he's from more than 4 years now, is the Executive of Save the Children. He will give us his own point of view of how pneumonia cannot be treated in isolation. Kevin, are you there?
I am here. Can you hear me, see me?
We can hear you and we can't see you yet.
I have my video on.
Now, I think your camera is off, Kevin.
No, my camera is on.
Let us double check. Can you hear us?
I can hear you.
Okay. So I think it's something between our cameras. Kevin, can you double check, please, if your camera is open?
Yeah, my camera is open.
Okay, I think the image is coming back or not. I think.
Do you? Should I?
Can you stop the video and try to enter another time, please, Kevin?
Okay.
Do you have like a sticker or something in your camera? I don't know. Well, we can go to. Okay. So we will go back later to Kevin Watkins after we can reconnect with him. Hopefully, we will not have problems because today, for the importance of the pneumonia diagnosis, we don't have to connect to the other side of the world. The next speaker is Professor Jordi Vila, who is the president of the Spanish Society of Clinical Microbiology and Infectious Disease. And he's the director of the Antimicrobial Resistance Initiative. He's not in overseas, he's right behind me. So I hope we don't have a problem with the live action. Thank you so much, Professor Vila, for being with us today.
Well, thanks a lot, Arturo, for this kind presentation. I would like to thank Dr. Katia Sillonis for inviting me to participate in this global conference today and discuss with all of you about the importance of pneumonia diagnosis. In the last decades, there has been several papers published in the scientific literature showing that when there is a delay in the administration of adequate empirical antibiotic treatment to treat hospital pneumonia, there is an increase in mortality. As you can see here in the different papers, an inappropriate therapy increase, doubling at least the percentage of mortality. So that means that we need a rapid diagnosis for hospital pneumonia. The rapid diagnosis allows us to, first of all, to have a good clinical outcome by, of course, targeting the right pathogen with the right antibiotic. Second, to reduce unnecessary antibiotic use and to perform a better antimicrobial stewardship, to increase the confidence to de-escalate antibiotics, and also to decrease several points such as cost, the drug toxicity, the diarrhea associated with Clostridioides difficile, and also the decrease in antibiotic selective pressure. In addition, the use of rapid diagnosis also help us in shortening the hospital or emergency department length of stay, and also to optimize the infection control practices. This is an scheme, an algorithm that we use in the clinical microbiology lab. And on the left side of the slide, there is the conventional workflow that we use. We take the secretion samples, the respiratory tract samples, and then send the samples to the clinical microbiology laboratory. When the sample arrives, we do a gram stain in order to analyze the quality of the sample, and we culture the sample. And next day we see if there is growing. There are growing bacteria in the culture, and then we identify the bacteria and we perform an antimicrobial susceptibility. So that workflow takes at least 24 to 48 hours. But we can also have some kind of molecular biology assays that can help us in performing a rapid test, either for community-acquired pneumonia, hospital-acquired pneumonia, and also ventilated-acquired pneumonia. We have, for instance, multiplex PCR to detect most of the viruses causing community-acquired pneumonia, plus the atypical bacteria. As we will see in the next slide, that takes from 1 hour to 9 hours, more or less. We also have two approaches, either a PCR or LAMP. LAMP is isothermal amplification to detect bacteria, mainly to detect the most frequent bacteria causing hospital-acquired pneumonia. And later on, once we have identified the bacteria, we can detect the mechanism of resistance to different antibiotics in this bacteria, and this resistance can be done or can be detected by either PCR or isothermal amplification. This is a table showing what we have currently commercialized in the detection of multiple microorganisms for community-acquired pneumonia. As you can see, all the panels include mostly viruses causing community-acquired pneumonia, plus atypical bacteria. Some of them also include SARS-CoV-2, and there are two groups of panels, of multiplex panels. The first two are the ones that are integrated systems. That means that you take the sample, you put the sample in an apparatus, and then after 1 hour you get the result. And the second group, it's taking longer. The first group is taking 1 hour. The turnaround time is 1 hour. And the second groups are non-integrated systems. That mean that you need from the sample to extract the DNA and then to amplify and detect the DNA. And this is why you take longer, from 3 to 9 hours. In addition, we also have in the market a couple of panels to identify most of the bacteria, viruses, and one of them includes even a fungi causing hospital-acquired pneumonia. And in addition, these panels detect the resistant markers. The first panel detected 8 different resistant markers, and the second one detected 17 resistant markers. The turnaround time for these two panels is 1 hour for the first one and 4 hours for the second one. We did a study trying to see, we set up an isothermal amplification and a LAMP to detect pathogens from respiratory samples. We set up the LAMP for 6 microorganisms causing hospital-acquired pneumonia: Cinetobacter baumannii, Pseudomonas aeruginosa, E. coli, Klebsiella pneumoniae, Staphylococcus aureus, and Stenotrophomonas maltophilia. And as you can see in this table, for when we use as a sample, respiratory sample, a bronchoalveolar lavage, the sensitivity was 80%, and the specificity was 85%. And when we move to the endotracheal aspirate or bronchoaspirate, the sensitivity went up to 95% and the specificity of 100%. And in addition, we could semi-quantify the number of bacteria in the sample, because there was a relationship, a correlation between the time to result using this isothermal amplification and the number of colony-forming units by ml. So it was a good correlation between these two parameters. In addition, we did a study trying directly from respiratory samples to detect some mechanism of resistance. In fact, we isolate, or we detect some carbapenemases. What we did is we took a bronchoalveolar lavage. We spiked this lavage with different carbapenem-resistant Enterobacteriaceae. And as you can see in this table, the sensitivity was really low, 10 to 2. So it's has a very good sensitivity, and also was a correlation between the inoculum and the CT. When we talk about PCR, let's see in the first 3 lines, we have 17 CT 17 for 10 to 7, 28 CT for 10 to 3, and 30 CT for 10 to 2. And the same happened with isothermal amplification with LAMP. We have 15 minutes, 18, 45 minutes, and 21 minutes. So there was also a correlation between the time or the CT and the inoculum that we have. So we proved that the LAMP and PCR can be used to detect carbapenemases directly from respiratory samples. The turnaround time for PCR was 50 minutes, and the turnaround time for LAMP was 30 minutes. This is a recent paper published in Clinical Infectious Diseases by IDSA. In this paper, IDSA analyzed the molecular testing for acute respiratory tract infections. They conclude, first of all, that the factors to introduce a molecular biology aside to diagnose respiratory tract infections are, first of all, the clinical setting, the institutional resources, the workflow, and also the cost. The bacterial detection of nucleic acids by amplification probably is useful in situations such as patients who have new or worsening lung infiltrates, patients with moderate or severe, who are moderate or severe ill, such as those which are immunocompromised, those who have received empiric antibiotics before obtaining the culture, and of course, when there is some concern about the presence of a multi-drug-resistant bacteria causing this pneumonia, or there is a polymicrobial pneumonia. These are the main aspects or approaches where you can apply the molecular testing. In addition, they mentioned that it's cost effective, this application of, or this use of molecular testing in pediatric patients, because you can reduce the unnecessary antibiotics, the use of antibiotics, and also a reduction of the chest radiographs. However, the current tests, this current molecular testing, are not yet replacing for bacterial and fungal culture, because we need the bacteria to do antimicrobial susceptibility testing, and also this antimicrobial susceptibility testing and the analysis of the bacteria is useful for epidemiological studies, for vaccine-related decision, and also for local antibacterial susceptibility. A new tool that is emerging in clinical microbiology labs is the next-generation sequencing. Here I selected this paper published in Respiratory Research last year, when they use this next-generation sequencing to detect the bacteria found in respiratory samples. What these authors did, first of all, is to deplete the human DNA. When we extracted DNA, whole DNA or total DNA from a respiratory sample, we extracted human DNA plus the microbial DNA. So with a technique that they use, they deplete it from human DNA and they enrich the percentage of microbial DNA from 1% to 48%. They correlate the sequence that they have by using next-generation sequencing with the culture. I will not go in depth, but the correlation was excellent. Even in the first, for instance, the first sample, they detected Stenotrophomonas maltophilia plus E. coli, as you can see here in the case 1, Stenotrophomonas maltophilia plus E. coli, but E. coli was not detected in culture, so detected polymicrobial infection. The turnaround time of this next-generation sequencing applied to the detection of bacteria directly from respiratory samples is between 6 and 8 hours. So to conclude my talk, I would like to give these 3 take-home messages. The first one is that there is a clinical evidence that the rapid identification and determination of the antimicrobial susceptibility of the bacteria causing pneumonia helps in the implementation of an adequate antimicrobial therapy and therefore in the reduction of mortality. Second, either isothermal amplification or PCR can quickly detect the most common microorganism that causes bronchial ventilator-associated pneumonia or hospital-acquired pneumonia, and also ESBL and carbaphenemases directly from respiratory samples. And final, next-generation sequencing is a promising methodology for microbiological diagnosis, but it cannot be considered a rapid technique yet. And that's all. Thank you very much for your attention.
Thank you so much, Professor Villa, for your excellent presentation. As always, you're surprising us with all these new comings from the microbiology world. And I think now we can come back to Kevin Watkins from Save the Children's, who will give us his presentation that we kind of missed this past few minutes. I don't know, Kevin, if you hear us now?
I can hear you, and I think the camera is fixed. So, well, good evening. It's really great to be here with all of you. And I wanted to start by just saying a really huge thank you to Katia Chilones and everybody involved in organizing this event. It's so important that we keep pneumonia on the agenda. I think for at least two critical reasons. That first of all, the world has made commitments to eradicate preventable child death by 2030. And it's very clear from all of the presentations that we've heard today that even before COVID-19, that will not happen without accelerated progress on pneumonia. And I think the presentations today have set out some of the pathways to accelerated progress. But secondly, we know that COVID-19 and the pandemic, not just because of the health effects, but because of the social and economic effects and the disruption to health systems, actually threatens to reverse progress in child survival. And many of the additional deaths that are predicted, including by the Johns Hopkins Medical School study, are deaths that will occur as a result of misdiagnosed and untreated pneumonia. Around 40% of the 800,000 additional deaths predicted in that study are pneumonia related and related to malnutrition and pneumonia. So I think the issues that we're discussing are absolutely critical. I think I'm the first person so far not to be presenting a PowerPoint, which I should apologize for. But if I was presenting a PowerPoint, I would start it with one slide with two people on it. The first person would be the Prime Minister of the United Kingdom. And the reason I would put him on the slide is that you'll remember a few months back that he contracted COVID-19. It was diagnosed early. He was treated in a teaching hospital in London. And he emerged 4 days later, made a statement to the media in which he said, my life was saved because I was given liters and liters of oxygen. That oxygen was provided through a public health system free of charge to the Prime Minister. The other person I would have on the slide is a small child that I met in Jigawa State in northwest Nigeria, the country that Chizoba set out the data for on pneumonia. This was a little boy whose name was Nayo. He's 1 year old. I actually met him in a clinic where he was with his mother. He was clearly suffering from severe pneumonia. He had a very deep cough, a collapsed chest wall. It was the fourth time his mother had taken him to a clinic for treatment. He'd been misdiagnosed 3 times. And there was no oxygen in the clinic that he was attending when I met him. And in this particular case, his life was saved because it was possible to get him to a referral hospital that did have oxygen. But I think those two cases of somebody in a rich country where medical oxygen, one of the most critical essential medicines for keeping people alive in COVID-19, is freely available, where the oxygen infrastructure has been expanded in order to respond to the pandemic, and this appalling crisis in oxygen in the poorest countries, where hundreds of thousands of children every year have their lives put at risk because they don't have access to medical oxygen. And in many cases, they're being treated in facilities where, first of all, they're misdiagnosed, and where, secondly, even if they're accurately diagnosed, they would have to pay for the oxygen themselves. And of course, many are simply too poor to pay. So I think one of the really critical issues that we have to get on the agenda, if we're to deliver on the commitments that we've made to end preventable child death by 2030, is to tackle the crisis in medical oxygen. We know that every year in low-income and lower middle-income countries, around 4.3 million children are admitted to health facilities with hypoxemia. Many more, of course, never get to health facilities. But in the poorest countries, and especially in sub-Saharan Africa, fewer than 1 in 5 of those children are properly diagnosed and then properly treated. It seems to me that this is arguably the single greatest market failure in the health systems in the poorest countries around the world. And we have to fix that market failure as a matter of urgencies. Now, we've heard from various people what solutions to this problem might look like. And we have the work of Hamish Graham and researchers at the Murdoch School in Melbourne, in Australia, that have demonstrated very clearly that a simple combination of low-cost oxygen therapy with pulse oximetry can reduce deaths from pneumonia by around 50%. And of course, there are huge co-benefits in many other areas like sepsis and malaria. So addressing this crisis should be a matter of urgency. Now, it strikes me that in the response to COVID-19, there are many encouraging elements in that response, and in the ACT Accelerator program, which is seeking to make vaccines more widely available, which is making protective equipment more widely available. But I do think in the case of oxygen, the response has fallen far short of what children in the countries that we're discussing today have a right to expect. What they have a right to expect is that the failures in oxygen systems, which have been so starkly illustrated by COVID-19, where we're seeing black markets in oxygen in one country after another, that the proper response to that is to build an oxygen infrastructure to tackle the market failure that I mentioned earlier, that leaves some of the poorest people in the world paying some of the highest prices for oxygen in the world. That's a problem that needs fixing. What is happening, unfortunately, is that the agencies responsible for the oxygen component of the ACT Accelerator, the World Bank and the Global Fund, are not prioritizing the development of infrastructure. What is being prioritized is the transfer of concentrators, in some cases of ventilators, to urban hospitals for use in COVID-19 isolation wards. And it does strike me as profoundly misplaced when we have hundreds of thousands of children whose lives are being lost for want of medical oxygen. And the world responds to what is a pneumonia crisis by ignoring the underlying problem, the weaknesses in oxygen infrastructure, and concentrating resources for the treatment of adults for COVID-19. I think there are very positive examples which show there is an alternative. We have the Hewatele program in Ethiopia, where oxygen suppliers have come together around clusters of oxygen, dramatically lowering the price of oxygen and scaling up in response to the crisis. We have the program in Ethiopia, which is doing the same thing in Amhara region and operating really effectively. So I would encourage everyone who's working in research in this area to really think through how we can come together to tackle this really deep-rooted market failure, which is at the heart of so much injustice and inequality in the health system. I wanted to end by, apart from thanking everybody for the really brilliant presentations that I've had the privilege to sit and listen to make the observation that we have so much knowledge of what needs to be done to save lives, the lives of children from pneumonia. We know what the technologies look like. We know what the investments look like. We have the research that we need. What we're really lacking is the political momentum. And I think it's really incumbent on us to find ways of coming together in partnerships like Every Breath Counts, in national partnerships and global partnerships that can really drive change in this area. Because I fear that if we fail, the world will fall very dramatically short of that 2030 commitment that we've made. Thank you very much.
presentate two visions and two different continents. First, we will speak with Professor Giuseppe Aluch, which is the president of the Pan-African Thoracic Society. And then we will move forward to what is happening in one of the most beaten countries in Europe, which is Spain, actually. So thank you, Professor Aluch, for talking about how are you tackling with the pneumonia in the context of COVID-19.
Thank you very much. And let me also take this opportunity to thank Katia for this well-organization. Can you hear me?
Yes, we can hear you.
Thank you. The beauty of speaking at the tail end is that most people have already talked about what I would like to talk about. So I'll just tackle some of the challenges that's facing sub-Saharan Africa insofar as tackling pneumonia in the face of COVID-19 pandemic is concerned. Now, respiratory infection, we are all familiar with, is one of the biggest causes of disability in the world, and most so in Africa, and is the fourth leading cause of death. 13% of all hospitalization, particularly in the extreme of the ends of the life, are due to pneumonia or respiratory infection, and it affects highly the quality of life, health service resources use, and economic burden, particularly in Africa, and is the leading cause of consulting a doctor, leading to a number of people being given off duty so that they don't work and they don't earn, another cause, economic burden. And lastly, but not least, is the overuse of antibiotics, particularly over the counter, which is very common in sub-Saharan Africa and a major problem. Now, there's a bit of challenge, okay. Now, one of the commonest...
Can you hear me, Professor Aluch?
Can you hear me?
Yeah, I think that you have to click in the right part of your screen to get up.
I don't know what
to share again. To share again your screen. Presentation mode.
Presentation mode.
It's in the lower part of your screen, on the right side.
There, okay.
Brilliant.
All right, fine. Now, sorry about that. Now, the burden of respiratory diseases in Africa has multifaceted roots and often caused by rapid urbanization, with rapidly aging population in Africa, and of course, globalization with rapid transport, poverty, poor lifestyle practices, and weak health systems. But above all, lack of political will to tackle some of this problem, and worsened by increased environmental sanitation, particularly indoor population, which is very common in some places sub-Saharan Africa, particularly the type of fire or cooking methods used. You can see babies exposed to some of this indoor population at a very early age, and the biomass fuel is now becoming a very important cause of environmental population and respiratory diseases in Africa. So the problem has been made worse by the arrival of COVID-19 pandemic in Africa. Again, increased urbanization with densely populated slums, poor basic facilities, cannot facilitate any social distancing, and hand washing, which is very vital in COVID pandemic control, is a distant dream to a lot of this population. A large part of the population depend on formal sector, who cannot work from home. They cannot work virtually to earn a living. The economic effect of pandemic often worse than the disease itself. And the comorbid conditions, which are rampant in Africa, HIV, AIDS, TB, and pneumonia, make COVID-19 even worse. Poor resource, both human and material, in an already overstressed healthcare system can easily inflame the pandemic. weak economic status with no social cushioning make effect of COVID-19 pandemic economically devastating. And worse still, most of sub-Saharan Africa depend on importing medication, medical equipment, and make the system even worse. Malnutrition and disease cause COVID-19 more deadly in Africa than elsewhere in the world, and our health care system have very limited capacity to absorb the pandemic. So we need a better focus to deal with this pandemic in order to have it less disastrous. Pneumonia in sub-Saharan Africa has high morbidity and high mortality, and this has been clearly stated by the previous speakers, and we've seen, as in the previous presenters, in children is the leading cause of death, and in adults is a leading cause of hospitalization, and some of the risk factors have already been mentioned: poor nutrition, lack of breastfeeding, particularly in this African region, and exposure to in the population, overcrowding, and other infection, particularly HIV and other viral infection. Differentiating COVID-19 pneumonia and the other community-acquired pneumonia can be a challenge. Both of them are common, and with the limited diagnostic facility available for most remote areas in part of Africa, and no drug available to treat even the community-acquired pneumonia, leave alone the COVID pneumonia, we have still very little scientific evidence for many treatments for COVID pneumonia, and most of this is not yet filtered down to Africa. Oxygen has been mentioned many times. The limitation is interesting to know that oxygen is not always easily available to some of the areas where they may be hit by a lot of COVID in Africa, and critical care capacity, ventilators, trained staff is equally a challenge. And there must be some ethical issues to be addressed when we're talking about ICU access to some of the patients. And even when you have the ICU, we have a shortage of cadres, of healthcare workers that can efficiently manage the ICUs. With pneumonia, there's always an under-detection of the disease, and often some of the pneumonia pass undetected in sub-Saharan Africa. And finally, there's always stigma of COVID-19. So when it comes to diagnosis practically, there's always lack of facilities. There's high incidence of PTB, and particularly radiologically, that may confuse a lot of pneumonia, and it's very difficult to know which is TB and which is just only pneumonia in some of the cases, if you look at the X-ray alone. And even then, the radiological facilities are not always available in most places. In fact, the HIV infection and other infections make pneumonia or COVID pneumonia very difficult. So that in most of the guidelines now in most African, any pneumonia presented to the health institution is assumed to be COVID until proved otherwise. And all pneumonias are now being kind of isolated until you prove them otherwise. Because, and of course, this is giving a big burden to the health facilities isolation in dealing with COVID-19. As I said earlier, we still have less well-trained personnel to deal with some of these diagnoses. Our infrastructures, equipment, logistics, or reagents, and some of the regulatory facilities are not available. We don't have much of a reference laboratory, and there are some cultural values that affect even attitude towards some of these diseases like pneumonia, particularly COVID. People still prefer in sub-Saharan Africa just to pray or use religion or other aspects of traditional healing rather than the modern healthcare facilities. And this could limit the number of people who actually avail themselves to health facilities. So there may be a lot of people dying in the rural areas who do not come to the hospital. Not that there are no hospital, but still they prefer to use some of these alternative methods. So those are some of the challenges that are facing a lot of us dealing with pneumonia in Africa. And as time is up to conclude, pneumonia continues to present a major burden of morbidity and mortality in Africa, despite advances in preventative and management strategies. There is an urgent need for improved diagnosis to reliably identify some of the etiological agents and more widespread implementation of and scale-up of immunization with improved conjugate vaccine against childhood pneumonia in Africa could substantially reduce childhood mortality and the burden on pneumonia. Implementation of current effective preventive and management strategies remain a challenge in Africa, although the available interventions can substantially reduce pneumonia. And finally, the COVID-19 pandemic has affected the entire globe and continues to alter life as you know it. But as COVID-19 cases soar in the rest of the world, confirmed cases in Africa still remain comparatively low. With a population of 1.2 billion and with weak health infrastructure, experts fear that COVID-19 will severely impact the entire continent of Africa. This has not been the case. In fact, there are a lot of speculation growing why this has not been so. Maybe the youth bulge, the warmer climate could help spare most African countries, but we don't know whether we are over the worst yet. But at the moment, we can say that the worst is not yet here. Thank you very much for this opportunity.
Thank you so much, Professor Aluch, for your very nice presentation about how it's been the African continent on the COVID pandemic. We are having some breaking news from all over the world, from Canada, from Venice, from Dubai, from Valencia. We all have these beautiful landmarks enlightened in blue. And we are very happy and very proud that these initiatives are being heard in all over the world. So our next speaker is the past president of the Pan-African Thoracic Society. She is Professor Heather Sarpath. She is the professor and chair of the Department of Pediatrics and Child Health at the Red Cross Children's Hospital in Cape Town, South Africa. Thank you, Professor Heather, for being with us today.
Thank you so much, and good morning or good evening or good afternoon to you wherever you are in the world.
Thank you so much.
Really, thank you very much to Katya for the invitation to speak here today and to be part of this amazing symposium and this drive for better health, both for children and adults globally in terms of pneumonia and in the context of COVID. So my brief today was to talk to childhood COVID in the context of pneumonia. And the context of pneumonia has been so well set by many people, superbly said by many before me. We've heard over and over again how pneumonia is a major cause of death in children and in the elderly, that the burden's reducing but remains high even with the new vaccines like a pneumococcal conjugate vaccine, that the burden is skewed to sub-Saharan Africa and Southeast Asia, and to highlight that these are areas, and particularly sub-Saharan Africa, of great population growth and huge childhood populations. And against all of this, we now have the COVID pandemic. So we know in these contexts that there is a high prevalence of risk factors that we usually associate with pneumonia incidence and with pneumonia severity. And these include factors in the environment that have been alluded to: poverty, instability, smoke, maternal smoking, air pollution exposure, maternal factors including physical and mental health, and sub-levels of education, and then the child factors that are also have been highlighted in terms of malnutrition, HIV infection, and more recently HIV exposure as we've gained control of the HIV epidemic, prematurity and low birth weight, and the issues and the challenges to health systems in the context of already overburdened health systems with limited access to good prevention and treatment have again been highlighted. So when COVID broke, I think many of us were really fearful for what it would mean for the contexts of high burden childhood pneumonia areas. But what has actually happened in terms of COVID and in terms of child health and childhood pneumonia in the context of COVID? So first of all, to turn to COVID incidence and deaths globally, and this is WHO data. And you see here for different age groups, as the epidemic has proceeded, here to over 40 weeks of the report, that the big burden of disease, as we know, has been in either has been in adults, far and away in adults. The red bar here is 15 to 24-year-olds, then the light blue is 5 to 14-year-olds, and you can barely see the under 5-year-olds there, right, in the dark green. And if you dropped your eye down to the deaths, the children fall off. You don't see them on this graph. And so this tells us that there's much less COVID in children than we thought there would be, and there's certainly much less fatality, even though, of course, these figures are a function of testing and access to care. If we look overall at what has been reported globally, WHO estimates are that children make up 8.5% of cases. UNICEF has a very similar estimate of 8% of cases. In fact, I looked at the South African data yesterday. It's spot on. 8% of cases in South Africa who test positive are in children. And when I talk about children here, we are talking about, and I think WHO and UNICEF are also, we're not talking about children under 5, we're talking about children and adolescents up to 18 years of age. The incidence appears higher in adolescents, but overall, remarkably, the clinical presentation has been remarkably mild, ranging from asymptomatic infection or mild symptoms with relatively few severe pneumonia cases, and there is the emergence of this multi-inflammatory syndrome that is being seen, but again, that is relatively rare. And just looking at some of the data that has been published, for example, in South Korea, 4.8 with excellent testing and tracking, 4.8% of cases in children, despite them making up 18% of the population. And you can see here the childhood cases, and if you could just see that it's really concentrated in the 10 to 19-year-old age group. In the USA, the MMW report was that about 1.7% of cases are in children. This, I think, has gone up slightly, but again, to highlight, children form 22% of the USA population. And similarly in Europe, reports of mild disease and good outcomes overall in children. What's interesting, I think, is to look at these graphs, which show the percentage of COVID cases in children as a percentage of the overall caseload, stratified by high and low and middle income countries. And actually, these are conglomerated here, where this is low and middle income countries, including China. This is without China, and this is high income countries. And you'll see there seems to be a striking difference, that there is, in fact, a higher incidence of COVID in low and middle income countries, and that may reflect the childhood population, the population structures, with much bigger childhood populations in low and middle income countries. But overall, I think you'll agree that the averages are low, 10%, 5% of cases being in children and adolescents. What about severity of disease? And so looking at hospitalization and mortality in children, if you look at the summary of data from China, Europe, the USA, and South Africa, overall, the data is remarkably consistent. Children form a very few proportion of the hospitalizations for COVID, as I showed you in the first graph. 10.5 years. In South Africa, actually a third of those hospitalized were older than 15 years. So there is the adolescent signal there that seems to be behaving a little closer to the adult type disease. There are varying reports. Some say less are males, some say more are males. I think importantly, underlying comorbidity occurs in most of the reports of hospitalization or severe mortality. or mortality, and mortality is overall really low. In the South Korean cohort, there was no deaths. In amongst the USA reported deaths, there are very few, and that's consistent across countries. I think in South Africa, the case fatality rate is around 2.9%. What is also interesting, and in this analysis, and these are for different countries, mostly high-income countries here, what was shown that in fact is that there is actually much greater mortality currently, either from unintentional injury or from lower respiratory tract infection. And you can see there the numbers per 100,000, much more, tenfold higher than the COVID-related deaths, and here almost, what's that, about 30-fold higher. But I think COVID has had huge indirects on child health and well-being, and this has also been alluded to, and this has occurred in multiple ways. So lockdowns have had major economic impact, and impact on poverty, with subsequent, of course, direct impact on child health. Schools have been closed, and this has not only affected child mental health, child cognitive training, but also in our context, many children depend on school feeding systems. So again, the impact on closing schools on child nutrition is potentially substantial. Reduced access to healthcare has been alluded to, and people have spoken very clearly on the interruption in immunization programs and interruption in access to prevention and care. Diversion of resources to adult COVID priorities away from childhood resources. And all of these, I think, and I'll show you in the next slide, some of the modeling, estimate really a huge effect on child health. But one potential positive effect has been the impact of non-pharmacological interventions on other respiratory viruses and a lower respiratory tract infection, particularly for RSV and influenza. And to speak to both of these, so this was a modeling scenario. Leith also showed data from this in 118 countries that models three different scenarios, depending on access to healthcare and how the health system is impacted and whether there are lockdowns or not. And the figures are actually quite terrifying, that the estimates are an increase of anything from 10 to 45% in under 5 child deaths per month, and similarly very large increases in maternal deaths per month as a result of the indirect effects of COVID. But maybe not all doom and gloom, and this is unpublished data but has been submitted, and I just want to, it does show and this the impact of non-pharmacological interventions, I think, on other respiratory viruses. And so this is from the South African surveillance system, and it shows the incidence of influenza, both in ambulatory outpatient clinics and in admissions. This graph is a moving average of the years preceding COVID, that's 2013 to 2019. And the red graph shows the current season, so with COVID, and the different shades show the different times of lockdown. So, for example, here the deep brown is level 5, which was the most stringent lockdown, and then gradually as the lockdown was eased in South Africa. And what I think you can see is that initially there was the beginning of an influenza season here, and as soon as the lockdown was initiated, and with strong non-pharmacological measures, and in South Africa, what was made mandatory was national wearing of masks, and there was fairly good adherence to this, social distancing, and then a lockdown in which most businesses and schools were closed. And you can see that actually the influenza season has been ablated. We have not seen influenza in this time, both in ambulatory cases and in inpatients, and similarly for RSV. So here again is the RSV season in the preceding 5 years, both in ambulatory cases and inpatients. Keith spoke about the importance of RSV. It's the major pathogen causing hospitalization and mortality currently. And look what happened with our lockdown and with non-pharmacological interventions. It almost disappeared. And now with the easing of the lockdown, as businesses are opened, as schools are opened, and as there's less, I think, compliance with mask wearing, you see this increase in RSV cases, both ambulatory and inpatient. And this pattern is not, has also been described in Australia, certainly for influenza, and was also described in Hong Kong and in China, where there was marked reduction in other viral or respiratory tract infections that were diagnosed clinically as well as laboratory confirmed. So I think we may, in all of this, there may be some reduction in childhood hospitalizations for these pathogens, these key pathogens, with the very strict non-pharmacological interventions that have been introduced in some countries. So in conclusion, let me try and summarize just some of the key lessons that I think I've learned. Children are far less directly affected by COVID than adults. There are less infections, they develop less severe disease, and there's very little mortality, and the mortality that occurs is predominantly in those with underlying comorbidity. The non-pharmacological interventions seem to have reduced transmission of other viral infections. One could also argue that this may be lack of access to care, but there's no signal that there is an increased number of children dying outside hospital that has been picked up in our context or in other contexts. Children are, however, severely impacted by the indirect effects of COVID, with poverty, school closures, parental illness, impaired access to health, both preventive and care aspects, and there is a potential large increase in maternal and child deaths and ill health due to the indirect effects. Thank you very much.
Thank you very much, Dr. Saar, for your excellent presentation. It gives us a huge scenario of what will happen and what we'll have to expect during the next months here in Europe. Spain, you know, has been beaten strongly by COVID-19. We think at the very first beginning that this disease might be just treated by pulmonary physicians. However, it's been so huge and so tremendous, the impact on the daily basis, that we have to treat all these patients in several levels of attention. For today, we have the president of the Spanish Society of Internal Medicine, which is Professor Gomez Huelgas, that will give us the vision of what we have suffered in Spain in these past few months. Thank you, Doctor, for being with us today. Do you hear us?
Greetings.
Yes. Thank you.
Could you confirm me if I'm sharing my screen?
Yes, we see you. We don't see the presentation.
Okay. Greetings from Malaga, Spain. On behalf of the Spanish Society of Internal Medicine, I want to give thanks to the organization for this kind invitation to this symposium of World Pneumonia Day. As you know, the COVID pandemic has hit Spain with unexpected severity. The country ranks one of the highest per capita death rates around the world. As of end of October, there were more than 1 million confirmed cases and cumulative incidence of 360 cases per 100,000 people in the last 2 weeks. And in the last few weeks, these figures are getting worse.
Dr. Gomez Huelgas, we don't see the presentation.
You don't see?
We see you, but we don't see your presentation.
I don't know what could be the problem.
Just share the screen. There's a small button on the lower side.
Now? It's okay?
Yes.
It's okay.
Thank you.
Sorry.
Brilliant.
Okay. As I said, in Spain, around 3/4 of patients hospitalized by COVID-19 are admitted in internal medicine departments. Let me show the main data of the semi-COVID registry, a large, ongoing, nationwide, retrospective cohort of adult patients hospitalized in Spain with microbiologically confirmed SARS-CoV-2 infection, almost all of them with viral pneumonia. In this registry are involved more than 150 hospitals from all Spanish regions and currently includes more than 17,000 patients discharged by COVID. During the first wave, the mean age of patients hospitalized for COVID in Spain was over 69 years, most of them Caucasian, almost 60% male. As it being well described in other cohorts, we also found an important burden of cardiometabolic comorbidities with high prevalence of hypertension, obesity, diabetes, and cardiovascular diseases. At admission, the more frequent symptoms were fever, cough, and shortness of breath. About 1/4 of patients reported gastrointestinal symptoms, and in the physical exam were common fever, rales, and tachypnea. Near 20% of patients had oxygen saturation under 90% at admission. As it has been reported in other series, some complementary findings were associated with a worse clinical outcome. Pulmonary infiltrates in X-ray, lymphopenia, elevated levels of ferritin, LDH, and D-dimer. Regarding to the therapy, you can see that most patients hospitalized in the first wave of COVID were treated with hydroxychloroquine, azithromycin, and lopinavir, ritonavir, all drugs that currently have almost disappeared from our protocol. Interesting, more than 70% of patients were treated with beta-lactam antibiotics, an aspect that we'll analyze in detail further. About 1/3 of patients received systemic glucocorticoids, and anticoagulants were widely used, mainly low molecular weight heparin. Finally, 16% of patients needed some kind of ventilation support, and 5% invasive mechanical ventilation in intensive care units. Respecting to the complications, to highlight that 1/3 of patients developed acute distress respiratory syndrome, and bacterial pneumonia was registered in 11% of patients. The in-hospital mortality rate in our series was 21%. Aging and male sex were potent predictors of mortality, reaching a case fatality ratio higher than 50% in patients over 80 years old. An interesting finding from our Spanish registry has been the identification of 4 clinical phenotypic clusters that predicted in-hospital prognosis. The vast majority of subjects presented with the triad of fever, dry cough, and dyspnea. Cluster 1, characterized for this triad, showed the poorest prognosis, followed by cluster 4, characterized for the triad plus gastrointestinal symptoms. Cluster 2, characterized by ageusia and or anosmia in addition to the triad, was identified as the cluster associated with the better prognosis, together with cluster 3, characterized by arthromyalgia, headache, and sore throat, plus the triad of fever, cold, and dyspnea. Coming back to the patients with COVID-19 that developed bacterial pneumonia during hospitalization, 11% of them, we observed that these patients presented a double rate of in-hospital complications, such as distress, acute respiratory distress syndrome, sepsis, mechanical ventilation, intensive care admission, and death, in comparison with patients without bacterial pneumonia. It must be remarked that the fatality rate in patients with bacterial pneumonia was superior to 40%. When we analyzed the use of antibiotics in patients hospitalized for COVID-19, as I said, 60% of patients were treated with azithromycin and more than 70% with beta-lactam, while quinolones were used in roughly 10%. An important point is that the use of antibiotics was associated with a higher in-hospital mortality, with the remarkable exception of azithromycin, which could have a potential protective role. We specifically analyzed the appropriateness of prescription of non-macrolide antibiotics in patients hospitalized by COVID. In short, we consider appropriate prescription the use of non-macrolide antibiotics in patients with negative SARS-CoV PCR, shock or sepsis situation, procalcitonin equal or superior to 0.5, unilateral alveolar infiltrate, non-COVID-19 compatible CT image, cough with purulent expectoration or any other bacterial complication. Finally, I'd like to remark that the inappropriate use of antibiotics was very frequent, happened in almost half of hospitalized patients, and implies an increased risk of adverse reactions of other unwanted effects, including bacterial resistance, without benefit for the patients. In fact, non-prescription of antibiotics in the absence of use of the good criteria was not associated with higher mortality in a multivariate analysis. We consider so that it's crucial to define criteria for the right use of antibiotics in patients with SARS-CoV-2 infection. In conclusion, lung infiltrates were an almost universal finding in patients hospitalized by COVID-19 in Spain. The vast majority of subjects presented with the triad of fever, dry cough, and dyspnea. The presence of ageusia, anosmia, flu-like symptoms, or gastrointestinal symptoms seem to be associated with a better prognosis. Bacterial pneumonia was diagnosed in 11% of patients and was associated with a poor outcomes. And inappropriate use of non-macrolide antibiotics was frequent, around 50% of patients, and it was associated to a higher rate of adverse drug events. Thank you so much for your attention.
Thank you very much, Professor Huelgas, for your kind presentation. It gives us all about the huge scenario that we have been struck in Spain. It's a lovely registry, and we are eager to have all this data published to see it. We thought at the very first beginning of COVID-19 that we will be struck in all that we see in the news is what is happening in hospitals, what is happening in the intensive care unit, but we didn't know how we'll be struggling in primary care physicians after the first wave of the pandemic. So for telling us what is how to live and how to deal with it, we have Dr. Zaira Correcher, which is the International Director of the Spanish Society of Primary Care Physicians, who will tell her vision of what is happening and what will happen and what has actually happened before in this pandemic. Thank you, Dr. Correcher, for being with us today.
Thank you. Welcome, everyone, and thanks for joining us. I hope you can see my presentation and hear me without problems.
We hear you and we see you. Thank you.
Okay, thank you. My name is Zaira Correcher. I am a primary care doctor and the international coordinator of the Spanish Society of Primary Care Physicians, Emergen. First of all, I am very pleased to be part of the Global Conference for World Pneumonia Day, and I would like to thank Katia and the organization for inviting me and giving me the chance of explaining the pneumonia within the COVID context, seen from the primary care side. Wait a moment. Okay, it works. Why is it basic to talk about pneumonia? Pneumonia is an inflammatory disease generated in the respiratory system, which can get to be life-threatening, especially between elderly people and immunodeficient people. Although it is not appreciated sometimes, it is an important illness. As numbers reflect, between 9,000 and 10,000 patients die due to pneumonia in Spain. Moreover, that means a great expense or cost of hospitalization. 274 people are hospitalized every day in Spain. 41% of adults over 18 require hospitalization. Elderly people can be hospitalized nearly 13 days, which means an increase of the expenses. In addition, older than 65 have 4 times more risk to develop a cardiovascular disease 30 days after hospitalization for pneumonia. The following graphic shows the annual evolution in deaths attached to pneumonia from 2006 to 2018 in Spain. In this last year, the number of deaths due to this illness was 10,415. The greatest number reached 80% of these deaths are people over 80 years old. If we have a look at the geographical areas in Spain, we can check that there are some communities which double the mortality rate. For instance, Catalonia and the Basque Country have a mortality rate of 12.5, 13.5 within 100,000 inhabitants, whereas Extremadura or Murcia show a mortality rate of 28, 29 for 100,000 inhabitants. That is what's happening in Spain. But what about Europe? As we can see in the following image, the mortality rate in Europe is also high. More than 131,450 people died in 2016. In the European Union, the mortality rate from pneumonia within 3 years is 26 people dead for 100,000 inhabitants in 2016. Spain is placed under this average, distant from countries like Portugal, Slovakia, Polonia, or Malta. In the following map, the affectation of the different countries within the European Union is reflected. The orange and the dark yellow show the countries with the greatest mortality rate, like Portugal, UK, and Poland, although some disparity exists between regions within the countries. But what about pneumonia in primary care? Pneumonia diagnosis in primary care is important since it requires a specific medical treatment to avoid the deterioration of the patient. It is based on the symptoms, signs, and image evidence like chest X-ray. Normally, the patient shows signs of infection in the lower respiratory tracts, like cough, fever, expectoration, maybe not in the COVID at all, chest pain, dyspnea. In the medical history, we need to consider age, comorbidities, chronic diseases, smoking, long corticosteroid treatment, recent hospitalization, etc. Although normal auscultation does not dismiss pulmonary condensation, crepitations or bronchial wheeze or oxygen saturation in a deep exploration increase the suspicion of pulmonary condensation. In the chest X-ray can be found some condensation, interstitial infiltrates, or even cavities, but bilateral pulmonary infiltrates or ground glass opacities make us think in COVID. There are some healthcare centers provided with ultrasounds from which B-lines and air bronchogram images can be obtained. Depending on the reaction of, depending on our patient general condition, or depending on the reaction of the patient to the treatment, for example, if there is a lack of reaction to the empiric treatment or a suspicion of aspiration, it may be necessary to relocate the patient into a hospital to complete the check. Polymerase chain reaction test if it's not done yet. Blood tests looking for C-reactive protein, ferritin, neutrophil, lymphocytes, or more images tests like chest CT scan, which may not show new information, but it may be helpful in case of doubt or in order to help treat pleural complications. Regardless, once the diagnosis is established, it is necessary to set an assessment of the gravity and the prognosis, which will decide on the treatment or patient or in hospital. In order to do that, different scales can be used, like CORD, FINE, or early warning score. Dealing with outpatient treatment, we need to take into account the separate recommendations, and then we can provide the patient amoxicillin, clavulanic, quinolones, or other alternatives like microlide or cephalosporins. But the pandemic situation has forced us to accept different changes, problems, and challenges we need to adapt to and overcome daily with the available resources in order to guarantee our patients' attention from the healthcare centers. It has supposed a salutary lesson in the consultation. So new technologies, even though there is still a lot to improve in the available resources, have become the most used resource against face-to-face attention, and phone calls and video calls have come to stay. It is true that a fear to a quick increase of the disease has grown the patient referrals to hospital in COVID patients. However, most of these patients are diagnosed and treated in primary care. And this is why Semergen has developed an algorithm to improve the consultations via phone calls and video calls, and an action protocols to treat COVID patients in primary care, which can be found in Semergen website. It is necessary a plan and some previous information that allow us the telematic attention of the patient. For instance, depending on the age, internet access, phone availability, etc., a video call can be held or not. For example, knowing that a patient is a deaf mute will force us to a face-to-face attention or telematic attention with a translator. Dealing with telematic consultation will require a bigger control for the own patient about his diseases, and that includes the vital signs reading. Sending clear, short, and easy messages, answering questions, making the patient feel accompanied or not abandoned by his doctors and nurses are very important points that we have to transmit to them. We need to listen to the patient, taking into account the time and paying attention to elements that give us information about his general condition. For example, identifying a dyspnea from a difficulty to speak or make long sentences. Finally, summing up interesting data for the diagnosis, treatment, and referral if it is required, and insisting on calling us if they get worse or have a doubt, gives the patient feeling of security. So we can continue with an outpatient follow-up and make a medical referral based on warning and alarm symptoms and signs. And that's all. Thank you everyone for your attention.
Thank you so much, Dr. Correcher, for your point of view. It's really interesting how we in primary care are tackling with the disease. It's not the same what we are seeing in the intensive care unit. So what is seen in the hospital, what is in the emergency department. And it's really nice to see how everyone is evolving, but actually at the same time, we're adapting to this pandemic. So for the third and the last block of the symposium, we've been talking about how the importance of speaking about pneumonia is. We've been speaking about how are we tackling all over the world about childhood pneumonia. We also been talking about the microbiology diagnostics and how we're tackling at different levels in hospital intensive care unit or primary care. But how are we doing in terms of information? We are probably not really doing okay in terms of information facing these things to the population. And for that, we have Dr. Hansen, which is now the president of the European Lung Foundation, who will help us on how to tell the information and how this information can adapt to general population about pneumonia. Thank you, Dr. Hansen, for being with us today.
Hello, and thank you so much for the introduction, and thank you for the invitation to speak here today. So, as said, I represent the European Lung Foundation, and what we do is, in partnership with the European Respiratory Society, we bring together patients and the public with healthcare professionals in order to improve lung health. And a part of our mission is then to give reliable information to the public that is trustworthy about lung health and diseases, and to do so in their own language. We experienced during the COVID situation a lot of questions and contact from the public. And I'm here to share some of the lessons that we have learned from the COVID-19 situation. So misinformation is, of course, dangerous, and we have to take care before we share. And the reason I can speak about this with confidence is that we got a lot of questions from the public. And we, in collaboration with the European Respiratory Society, we set up a page where we could handle these questions and get answers and input from some of the respiratory professionals in the European Respiratory Society. So here's just one example of the questions that we got. I'm generally healthy, but have had pneumonia several times. Does this mean that it will be affected, that I will be affected more severely, is the question. And we have lots of these and similar concerns that we interacted with, both people who sent us questions and, of course, also people who were interested in reading other people's questions and the answer that follows. So during the period from 1st of March until 13th of July this year, we had a total of more than 300,000 visitors to our Q&A sessions from 227 countries and territories. And we have a little selection here where you can see that there are both a lot of European countries that interacted with us, or residents in European countries, but also a lot of residents from the Americas, especially from South America. And we then proceeded to collect all this information in a COVID-19 section on our webpage on the europeanlung.org, where we could share all this information and where it was interacted with. And we learned then a few lessons from the period that we have been through. So what makes good information? Point one, good information is created in collaboration between patients and professionals. So we did not only experience that our visitors felt really well informed from visiting our website, but we also experienced that we were able to give good feedback to European Respiratory Society and professionals working there about the information that we received from our visitors, and then also we were able to help and relieve all the general practitioners and the hospitals that were overloaded during that period. So for lesson number two, good information is reliable, it's quality checked, and it's available in multiple languages. So that is something that we work on with especially one of our committees, the professional advisory committee that we have in our organization. They help us develop these fact sheets, and then we have a two-tier system where we control the translations afterwards. So for lesson number 3, good information is easily accessible. It takes issues such as health and digital literacy into consideration. And for that aspect, we are interacting with a lot of lung groups, and we have our own patient advisory groups helping to advise us on what is good information. But I think it's important also to have this context of digital literacy and health literacy in mind when we develop information. So for lesson number 4, good information considers equitable access issues. It is designed to address the needs of, for example, minorities and at-need groups. So we have all our information available in multiple languages, as you can see here, and also for download in very specific languages to address some of the minorities that are also residing within the European continent and abroad. So for lesson number 5, good information can create fun and engaging way of interacting. So we are not only providing this information in terms of fact sheets and Q&As on our website, but we also have our Healthy Lungs for Life campaign where we visit cities when it is possible, of course, and interact with people on plazas and so on in some of the major cities. And hopefully we'll come to Spain next year. So some of the challenges that we experience are related to the information of pneumonia. Is that pneumonia is a serious and acute condition, but there's few patient organizations that really focus on it, meaning that we also have to cultivate the specialized information. It is also hard to find and involve people who have had pneumonia in activities in regards to developing the information. And people who have had pneumonia might experience problems long after treatment and may not relate them to pneumonia. So there's also the issue of forgetting or maybe not making a direct connection. And then the last point is that people with pneumonia are often not in a fit state to read materials and may rely on carers to inform them. So we also need to interact with the carers. So in terms of our pneumonia resources, then we have specific fact sheets that are downloadable and accessible from our website that deals with pneumonia. And of course, we always have or we also have additional resources like acute lower respiratory infections and so on. And we always have the option to develop information that is needed with our experts and patient groups. So finally, we wanted also to take action in the light of this symposium and to pledge to update all our information on pneumonia and to ensure better multilingual information for the people infected by pneumonia. So that's our pledge to you and to the public in light of this conference. And you might feel free to visit us at these web locations and also social media locations. So thank you very much for the opportunity to speak today.
Thank you very much, Dr. Hansen, for your kind presentation. We will visit shortly the website to see all the pages and all the resources we have for all the patients to see them. We want to go further to our next speaker today, which is Dr. Stephanie Levine, which is the president of the Forum of International Respiratory Societies, which agglutinates a lot of number of respiratory societies in there. And we want to know what is her point of view of what we're doing good and what we're doing wrong about information of pneumonia. Thank you, Dr. Levine.
Thank you so much, and thank you for giving me this opportunity to present on behalf of FIRST. Can you see the slides and hear me okay?
We can see you, we can hear you.
All right,
thank you.
Excellent. Thank you. So the importance of information in pneumonia. I have no conflicts of interest as is related to this presentation. So I'm starting out with a definition of information. We know it's a noun, It's knowledge communicated or received concerning a particular fact or circumstance. Knowledge gained, oops, sorry. A knowledge gained through study, communication, research, instruction, and it's factual. So a little bit about the scope of the problem, much of which we've heard throughout the excellent sessions earlier in the program. Lower respiratory tract infections and specifically pneumonia remain a leading infectious cause of death worldwide. The most common fatal infection presenting to hospital in both the developed and developing world. The mortality rates, as you have heard, remain fairly static. And some of our challenges include antibiotic resistance, newer antibiotic resistant pathogens, HIV, and then just in this past year, pandemic viruses such as what we're experiencing currently with COVID-19. And a historical graph looking at, on your y-axis, mortality rate per 100,000 population, on your x-axis are dates, and one can see we're very familiar with the 1918 influenza pandemic. Unfortunately, we're seeing much of what was seen then is what we're encountering now in our trends. We have in the 30s the initial identification of the influenza virus, penicillin, 1940, 41. Influenza vaccine, the first one was developed a little bit in the early 40s, around 43. And then we have in the 60s and all the way up until the 90s, newer antiviral agents have been developed. But one can see, interestingly, on your y-axis, in terms of mortality rate per 100,000 population, even since then, in the 40s, there has been, yes, a decrease, but it's relatively flat, so certainly a problem. Looking at the GBD 2016, the Lower Respiratory Infections Collaborators Global Burden of Disease Study, one can see that estimates of the global, regional, and national morbidity, mortality, and etiologies of lower respiratory tract infections, and this was over 195 countries, and it spanned the period of 1990 to 2016. And in the year of the study conclusion, 2016, one can see that lower respiratory tract infections accounted for more than 650,000 deaths in children under 5, over 1 million deaths in adults older than 70 years, and over 2 million deaths, well over 2 million, in people of all ages worldwide. And that was in a single year. And what we have heard earlier in this symposium and in the Congress, in terms of death rates from pneumonia by age, one can see again on our y-axis our death rates, x-axis are years, that although that there has been improvement in some areas of the world in mortality due to pneumonia in children under 5, although we certainly saw areas where that was not the case, one can see that that drop is much less apparent if you're over 70, and pretty much in all other age groups, the mortality rate has been fairly steady since the early 90s. The pathogens, as again we have heard about, most commonly in all ages, pneumococcus leads the list. That is true in children under 5 and in elderly adults as well. And we know that worldwide pneumococcus is a leading cause of morbidity and mortality related to lower respiratory tract infections compared to all other etiologies. So as we talk about information and how it is presented here, I think we're all familiar with a brand new way of presenting information, a live updated information that's updated daily, hourly, sometimes even more than that. This, I took a screenshot a couple weeks ago on October 14th. I checked on these numbers this morning. The global cases had gone up to over 52 million. The US cases over 10 million. And in my state, I live in Texas, over 1 million in the state of Texas. So that's in just a little bit over 2 weeks of time. So it's predicted that morbidity and mortality related to pneumonia will worsen, where we have a more elderly population. Our patients and population have increasing number of comorbidities such as diabetes, COPD, obesity, ongoing smoking compounds this problem. There are more, say, solid organ transplants and other rheumatologic conditions, for example, malignancies that are requiring the use of immunosuppressive drugs. Climate change, as you heard earlier, and the increasing air pollution can also worsen this situation. And then now we have a pandemic. So why is this a problem? Well, let's break it down a little bit further. The sense of emergency related to pneumonia is lacking. The sense of severity is lacking. We think of it, in older patients with other diseases, and that's not always the case as we now so blatantly are aware. Who gets infected? Again, information is lacking in that area. Again, we think it's elderly, perhaps small children, patients with underlying diseases. Again, we know that is not the case, so we need to disseminate such information. There's also a wrong impression that there are limited sequelae of pneumonia, and we know that once you survive the initial event, you are at increased risk of morbidity and mortality following that for at least the first year, perhaps longer. Low vaccination rates, again, could be an information problem, an education problem. We know pneumonia is a financially neglected disease. There are sufficient funds put towards other chronic respiratory diseases, asthma, COPD, and those that are rare in high-income countries, but particularly in high-income countries in the US, a lot of money goes into pulmonary hypertension and interstitial lung disease. So certainly a smaller number of patients affected by those diseases, but quite a bit of money is going into research in those areas. There's little money in relation to pneumonia that's devoted to the diagnostics, antibiotics, and therapeutics. In addition, clinical diagnostic and therapeutic recommendations are generally lacking. We were so happy last year to have an updated community-acquired pneumonia guideline, but that had not been updated since 2007. A scope of awareness is lacking. There are neither patient associations devoted to this, nor clear advocacy strategies, resulting in a lack of awareness. As we just heard from our prior speaker, there certainly are ways that we are trying to improve this, but it is still a problem. We have a COPD coalition, we have a pulmonary fibrosis foundation, but we don't have a specific pneumonia advocacy group. And then overall, what this comes down to is a lack of widespread education. So some of the solutions, we have to increase awareness in the areas of research, pharmaceutical agency, regulators, public agencies, increase funding, increase resources devoted to pneumonia both locally and globally, increase advocacy efforts, as we've heard from many speakers today, increase research, molecular, translational, and clinical, collaborate on clinical studies to improve our research efforts in diagnostics, therapeutics, and prevention. And then prevention, we need to raise awareness, improve education, educate people on modifying risk factors such as tobacco use, increase our rates of vaccination. So I'd like to conclude with information is the lifeblood of medicine. Pneumonia, as we've heard throughout the day, is a worldwide problem. We need more research. We need more advocacy. We need more education and information. And if we can attain this, our outcomes can be changed to improve outcomes for millions. With that, I'd like to thank you for your attention. And on behalf of FERS, these are the societies that we represent: CHEST, ATS, the Asian Pacific Society of Respiratory Diseases, ALOT, ERS, the Union, the Pan-African Thoracic Society, Global Initiative for Asthma, and Global Initiative for COPD. Thank you.
Thank you so much, Dr. Levine, for giving us this overview of what we're doing good and what we're doing wrong, about the information on how to tackle all these diseases. We need a lot to do. We need a lot of funding. We need a lot of research to do that. Of course, we need money to do research on pneumonia, but actually we also need we as a doctors or as a professionals to put all our effort into doing some good guidelines about this disease. Our next speaker is Dr. Juliet Awori, which is the Wellcome Trust Research Program Director in Kifili, Kenya. And we want to know, we're eager to know what is your experience when how to handle information in Kenya. Thank you for being with us today.
Thank you. Can you hear me?
Yes, we can hear you and see you.
Great. So thank you very much. And thank you very much for this opportunity to speak today and to add my voice to this very critical issue. But I am not the director of KEMRI Wellcome Trust Research Program in Kilifi. I am a medical doctor in the final year of my postgraduate studies, and I am studying the appropriateness of the World Health Organization case management strategy for lower chest wall injury pneumonia in primary level facilities in Kilifi, which is a rural coastal town in Kenya. So I'll start off my talk with a little bit of a flashback. In the 1930s, as you can see on this health education poster from New York, pneumonia was news. Pneumonia was known as a deadly disease, maybe a little bit like what we're experiencing today. Many people who got pneumonia died, and health messages were often crafted to educate the public on the subtle nature with which pneumonia started and its potential for fatal outcomes and the importance of seeking care. And now, almost 10 decades later, pneumonia is still a deadly disease, and particularly in children under 5 years of age. And the health message to recognize the disease early and encourage care seeking is just as relevant today as it was then. And without belaboring this very important fact, let me reiterate that pneumonia is still the leading cause of death in children under 5 years of age, even after 40 years of strategic efforts to reduce the global burden of childhood pneumonia mortality. And what's more, children from poor, impoverished communities in low and middle income countries continue to bear the brunt of pneumonia mortality. The Integrated Global Action Plan for the Prevention and Control of Pneumonia and Diarrhea, which has been mentioned today, was set out in 2013. The World Health Organization and UNICEF called on governments and all stakeholders to implement integrated approaches to end preventable childhood deaths from pneumonia and diarrhea by 2025. The strategy builds on a three-pronged approach dubbed the Protect, Prevent, and Treat framework. It calls on the use of existing interventions that have been tried and shown to work. The focus of my talk today is on the strategy to treat. Currently, the IMCI program is widely used in primary healthcare settings in low and middle income countries. The integrated management of childhood illnesses comprises standardized patient management plans that were developed by the World Health Organization in the 1980s and 90s. And for pneumonia, these guidelines were designed for use in resource-constrained primary healthcare settings to reduce mortality by ensuring early case detection and consequently early initiation of antibiotic treatment or referral of severe cases. Now, early access to antibiotic treatment is an effective strategy, and more so because childhood pneumonia mortality is mainly attributed to bacterial causes in high burden countries. However, for a sick child at home to receive this potentially life-saving antibiotic treatment early, several processes have to take place and take place effectively. Parents or caregivers need to be able to recognize early signs of pneumonia in their children. They need to know what signs or symptoms to look out for and which ones require medical attention. In the same breath, they need to seek medical attention from the correct healthcare provider in a timely fashion. And once in contact with a healthcare provider, the healthcare provider needs to be able to accurately recognize or diagnose pneumonia and prescribe the correct treatment. In addition, they need to be able to provide effective medical advice on the treatment, home-based supportive care, and clinical follow-up to these parents. And lastly, the parents or caregivers need to adhere to the treatment advice given, and they need to be able to give the antibiotic medication correctly for the required duration of time and adhere to the advice for home-based supportive care and follow-up advice given. Now, these distinct processes in the pathway to care for pneumonia not only illustrate the importance of ensuring that healthcare providers are trained and that health systems are adequately resourced to support care at the primary level, but they also emphasize the critical role that parents or caregivers play in ensuring survival of the sick child with pneumonia in the developing country, and more so in a rural setup. And while these processes seem straightforward at face value, research findings continue to show that there are opportunities for improvement. This is exemplified in this audit of pneumonia case management practices that I present by primary healthcare providers. And these providers comprised of nurses and diploma level clinical officers. We conducted this audit in 5 dispensaries and health centers in rural Kilifi between May and September of 2018. And for the audit, we visited the facilities on random days over a duration of 6 weeks. A trained study doctor performed a second examination per the pneumonia IMCI guidelines on all children who presented with a complaint of cough or difficulty in breathing within 10 minutes of the initial assessment by the facility clinician. We then compared the study doctor's assessment to the actual diagnosis and management plan given by the facility clinician. In summary, while the study doctor detected pneumonia in 31% of the cases, only 9% were diagnosed as having pneumonia by the facility clinicians. And none of these cases were actually classified using the IMCI severity classification for management. And these classifications are important in guiding treatment decisions at that level. Moreover, we found that an antibiotic was prescribed to 77% of the cases seen by the clinician, regardless of the indication, and only 48% received the actual recommended first-line antibiotic for pneumonia per the IMCI guidelines. We followed this audit with training of the facility clinicians and thereafter an observational study to assess for treatment outcomes and adherence practices of the parents providing home-based care for children with pneumonia. And in this study, we focused on pneumonia characterized by lower chest volume drawing. And although this study is still ongoing, preliminary findings show that approximately 12% of children treated at home either still had case-defining symptoms of pneumonia, that is lower chest volume drawing, on day 5, by which time they were supposed to have completed their treatment, or they were hospitalized or had actually died. While this study is not powered to assess for the association between adherence and treatment outcomes, we are finding that 45% of parents had only completed 3 or less of the 5-day antibiotic course prescribed, and 69% of the parents did not return for review on day 2 as per the advice given. And this proportion was significantly higher in the more rural areas. Having said that, I'd like to share some reflections as I finish my talk. Evidently, the pathway to effective treatment is marred by poor practices by both parents or caregivers and primary healthcare workers, and this is often driven by inadequate information to them. To improve pneumonia outcomes in children, the role of parents and caregivers needs to be strengthened. In a sense, they are frontline healthcare providers for these children. Continued research and integration of research into policy and practice is needed critically. And this is particularly true for sub-Saharan settings that are lagging behind in this respect. Effective health education needs to be delivered deliberately and consistently to parents and caregivers to ensure timely access to antibiotics and adherence to treatment for the duration of the antibiotic course. At the same time, evidence needs to be translated to practice at the primary healthcare level. Primary healthcare workers need to be equipped with the knowledge and the tools they need to ensure that they are able to provide the correct diagnosis, the correct treatment plan, and that they're able to provide effective counseling to parents on adherence and home-based supportive care and clinical follow-up advice. Concerted effort is needed by all the stakeholders to ensure that ultimately life-saving information reaches the actual end users. Thank you very much.
Thank you very, very much, Dr. Julia Dawari, for what your presentation tells us about what you are tackling and how our information is important in Kenya. We were going through our last part of the symposium by giving the word to my friend and colleague, Cristina Dominido, which spent some of the time here in Barcelona in our research group. And she will do the proclamation of the Worldwide Pneumonia Awareness Campaign. She is now in Rome, in Italy. We've heard that a few minutes ago, that we have now 255 monuments or landmarks that are being illuminated in blue, and in 52 countries that we are really, really happy of this campaign that is touching everyone around the world. Thank you, Cristina, for being with us today.
Thank you so much. So before reading the final proclamation of this World Pneumonia Day, I truly would like to say thank you to Dr. Katia Sionis for the opportunity to participate to this great campaign. So pneumonia has been described as a 21st century disease, treated with 20th century therapies and diagnosed with 19th century tools. This is one of the reasons why pneumonia remains the leading infectious killer of adults and children, responsible for 2 million deaths, according to the 2019 Global Burden of Disease estimates. This World Pneumonia Day 2020 will be different due to the COVID-19 pandemic that has caused over 1 million deaths in every region of the world: Europe, America, Africa, Asia, and the Middle East. It should serve as a wake-up call to government, international health and development agencies, and all organizations with a stake in global health. The pandemic is telling us it is time to invest in healthcare systems that can prevent, diagnose, and treat respiratory infections. By 2030, pneumonia will kill 11 million children unless the world takes some action now. So to help increase the visibility of pneumonia and to raise public awareness of its risk, tonight, 263 iconic landmarks in 167 cities across 51 countries will light up blue to mark World Pneumonia Day. The campaign has been possible thanks to the support and the solidarity of several authorities and organizations all around the world. We have the responsibility for our children, our community, and our world. Good action gives strength to ourselves and inspires good action in others. Dr. Katia Sionis, coordinator of the campaign, thank you all of you for supporting the World Pneumonia Awareness Campaign.
Thank you very much for your words, Cristina. Very nice to see you again.
Thank you.
We will go back to the video that we missed from Mr. Sergio Rodriguez, which is the General Director of Pfizer Spain, because we want to hear what we missed in his words. Thank you so much.
Thank you.
Hello, everybody. I hope you all are fine. Every November 12th, the World Day Against Pneumonia is commemorated. A disease caused by infection in the lungs and normally caused by microorganisms, such as bacteria, viruses, and fungi. Pneumonia can be serious, but preventable in some cases. And according to the latest data available from the National Institute of Statistics in Spain, in 2018, it caused more than 120,000 hospital admissions, and more than 10,000 people died in our country. In addition, pneumonia is one of the leading causes of death and the first origin of sepsis. Although pneumonia is a disease with a high incidence and is known to society, the risk of contracting it is ignored. For this reason, we believe that it is essential, especially in the context in which we find ourselves right now, to sensitize and educate the population about this disease that can have serious consequences for those who suffer from it. In addition, with adequate prevention, the possibility of bacterial co-infections, SARS-CoV plus pneumonia, that would increase the burden of our health system could be avoided. On November 12th, coinciding with the World Pneumonia Day, the Pneumolite Global Campaign is launched, a project promoted by Dr. Katia Zilonis, researcher at the Hospital Clínic of Barcelona, with the collaboration of Pfizer and the support of the coalition Every Breath Counts from the University of Barcelona, the Barcelona Institute for Global Health, the Forum of International Respiratory Science Societies, and the Spanish Society for Infectious Diseases and Clinical Microbiology, amongst others. The campaign begins with a conference with world experts in the field that will address the importance of education and prevention to deal with this disease. Subsequently, a total of 48 countries will illuminate 232 monuments throughout the world in blue between 9 p.m. and 12 p.m. today, November the 12th. Specifically in Spain, 66 buildings and monuments in cities throughout the country will be illuminated in blue at that time with the aim of giving visibility to pneumonia. The importance of this campaign lies in the need for a good approach to pneumonia. Having an early diagnosis, effective treatments, and specific vaccination programs to prevent its onset is essential to avoid serious complications in the disease of death. It is necessary to influence the population that is more vulnerable to this disease, such as those under 5 years of age, those over 60 or 65 years of age, and people with previous chronic diseases, such as COPD, heart failure, liver disease, diabetes, or kidney disease. Good prevention is essential for them. In Pfizer, we are committed to improving the quality of life of people, and therefore it is very important for us to raise awareness about the seriousness of this disease to the population and make known what the existing measures for prevention are and its appropriate therapeutic approach with innovative drugs. Our commitment to research and development focus on both treating and preventing infections caused by difficult to treat resistant pathogens. We continue to evaluate opportunities and partnerships to expand our line of research and development to ensure we address the evolving medical needs of people and physicians in this important area of infectious disease. We have a strong vaccine R&D program, one of the largest in the industry, focused on developing vaccines to help protect against serious threats to public health. In addition, it should be noted that with the increase of pneumonia caused by COVID-19, many patients will develop associated bacterial pneumonias, for which we have a wide range of innovative molecules. Thank you very much, and I'm sure it will be a great conference today, and all the best for all of you. Goodbye.
Thank you so much for this video that we missed earlier by Senior Sergio Rodriguez, which is the president of Pfizer in Spain. For the official closing of this symposium today, we will have the presence of the General Director of Public Health here in Spain. And we have Dr. Pilar Aparicio, which will give you some words about what is happening today. Thank you so much. Dr. Aparicio, your audio.
De esta conferencia global sobre la neumonía, Light for Pneumonia Education and Prevention, 2020-2024, por delegación de nuestro ministro de Sanidad, que por motivos de agenda lamenta no poder estar aquí. En un día tan señalado, desde el Ministerio de Sanidad de España, queremos felicitar a los organizadores y patrocinadores por la celebración de este seminario en el día de hoy, en el que mundialmente se nos recuerda la importancia de la neumonía. Tal como dice el lema del proyecto Pneumolite de este año, la neumonía afecta a todos, las distintas intervenciones de la sesión de hoy han puesto de manifiesto los aspectos más destacados, reflejándolo con cifras y datos y con muy interesantes posicionamientos. Los aquí reunidos en este seminario virtual nos hemos hecho aún más conscientes de que la neumonía afecta a personas de todo el mundo y de todas las edades. Querría recalcar que en la concienciación del impacto de la enfermedad hay que señalar que la mayor morbilidad y mortalidad se produce en niños menores de 5 años y adultos mayores de 65. También las personas inmunodeprimidas o con patologías preexistentes como enfermedades crónicas respiratorias, hepáticas, renales, cardiovasculares y diabetes son los que más riesgo tienen. Ahora bien, los agentes de salud debemos poner en el radar todos los factores del riesgo sobre los que igualmente hay que actuar: el tabaquismo, el alcoholismo, la malnutrición, el hacinamiento o la contaminación ambiental. En el seminario de hoy se han contado intervenciones de expertos mundiales que nos han concienciado de que en el caso de los niños la neumonía constituye la causa principal infecciosa de muerte a nivel global. Destaco, por ejemplo, un dato entre los que se han expuesto. En 2017, según la OMS, algo más de 800.000 menores de 5 años murieron por esta causa, fundamentalmente en países con pocos recursos, en los que se suman factores de riesgo como la malnutrición o el hacinamiento y el acceso limitado o nulo a la vacunación y al tratamiento con antibióticos. Hablar de neumonía como un problema de salud mundial en contextos vulnerables no puede alejarnos de hacer la siguiente reflexión. En España, la neumonía no tiene la misma importancia que en otros países con menos recursos, pero aún así, el INE, en el Instituto Nacional de Estadística, reflejan alrededor de 10.000 defunciones al año por neumonía en nuestro país. En países de nuestro entorno se encuentra un escenario similar. Nuestra visión es que el abordaje integral de la neumonía requiere un diagnóstico y tratamiento precoz, así como llevar a cabo acciones para su prevención. Esta tarde se han hecho intervenciones con ese planteamiento. La neumonía no puede tratarse aisladamente y no podemos dejar a nadie atrás. El Ministerio de Sanidad de España impulsa políticas de calidad asistencial, promueve estilos y entornos de vida saludables. Por ello, se planifica, coordina y desarrolla, junto con expertos y comunidades autónomos, el calendario de vacunación para el Sistema Nacional de Salud, en el que se incluyen vacunas para las neumonías bacterianas más frecuentes. Este año, y como se comentaba en este seminario de hoy, la extensión mundial de la pandemia ha hecho que la neumonía sea tristemente protagonista. Esta pandemia de COVID-19 ha hecho que países con una población envejecida como España, donde el foco se había puesto en los últimos años principalmente en patologías crónicas, dirija nuevamente su atención hacia enfermedades infecciosas con potencial pandémico. El fortalecimiento de nuestros sistemas de vigilancia y prevención es sin duda una lección aprendida en la lucha contra la pandemia. Por eso, próximamente pondremos en marcha una estrategia de vigilancia centinela para detectar todo incremento de infección respiratoria en atención primaria como infección respiratoria severa en nuestros hospitales. Es en este día en que conmemoramos el Día Mundial de la Neumonía, agradecemos la iniciativa Pneumolife. Estamos convencidos que esta interesantísima y completa conferencia ha contribuido a conseguir el objetivo de aumentar la visibilidad, concienciación y educación sobre la neumonía a nivel mundial. Muchas gracias de nuevo a todos y a todas los participantes en este simposio. Muchas gracias.
Thank you so much, and thank you for the official closing of this symposium. We've been in the past hours sharing with people from all over the world what we think about pneumonia, what are the major diagnoses, how are people tackling with pneumonia in COVID-19, and we want to present you the video of the Pneumolife campaign. Thank you so much for the invitation. Thanks for Katia for organizing all this. Thanks for all the initiatives of all the people around the world. And remember, wash your hands, social distancing, and use your mask. Thank you.